Bismillah ar-Rahman ar-Rahim. I would like to welcome you all today in our 41st annual Congress for the Faculty of Medicine at Ain Shams University. Actually, it's not only a Congress, it's a sort of medical week, and the idea emerged some 4 years ago when we decided to join forces and to unite all departments, whether clinical or academic departments that used to have their annual Congress alone and single-handed. The visibility within the faculty, within the academia was not enough. That's what I believe by that time. So the decision was to try to get everybody together on board. A sort of multidisciplinary, interdisciplinary medical week, uniting all departments together to see each other, to share ideas, thoughts and insight with each other, not only within Ain Shams Medical College, but with their peers in Egypt, all sister faculties of medicine in Egypt, in the region and globally. And that's why we are very keen to host our friends and colleagues from around the globe, from the west and east, from the north and south, to share with us their thoughts and ideas and experience, and to end this week by MOUs, by partnering, by any sort of agreements for future collaboration, including training for nursing staff, for doctors, for young doctors, for even attending doctors, for paramedics, for research above all, and for joint international publication. One of the good things that we did during the past few years also is to raise a dedicated medical research unit or department called MASRI, which is concerned with basic research, translational research and clinical research, and I believe it's a very good platform for our colleagues in Ain Shams University and their colleagues and peers from different disciplines to work together and to showcase all their work and experience in a sort of joint publication to the whole world. Coming to numbers, I believe that this 41st annual medical week in the premises of Ain Shams Faculty of Medicine that will start on the 21st and goes until the 27th. I hope that I can see you, at least or some of you physically, by the end of this week, participating 10 academic and 20 clinical departments all together, with invited 25 guest speakers and 7 working days and up to 126 total working hours. And this has been accredited by the European Accreditation Council for Continuous Medical Education. I cannot end my word without touching on what we all are witnessing in the world over the past, I would say, 1 year nearly now, since December 2019, when the COVID-19 pandemic hit the whole world very hard, I would say, without any exception. And I think this was challenging to all of us. One of the challenges that we are meeting today, and that we online, and we are doing it more or less virtually rather than physically as we used to do. But I think within the challenges that we all met over the past year, there have been some opportunities. One of them is the marked advancement, and thanks to the IT and technology, that we are more and more on webinars, daily and hourly webinars, virtual meeting, exchanging expertise. It didn't stop us in the academia, whether when it comes to e-learning or hybrid learning or any sort of acquiring skills. Obviously, we need physical existence, and we need physical meeting face-to-face for certain skills and for certain experience to be shared and to be exchanged. I'm sure that it will not be for long, and we will soon have more than one vaccine in the globe and an accurate treatment for the COVID-19, and I wish you all the best, and please stay safe. Thank you very much.
honor to announce the 41st Annual International Ain Shams Medical Congress. It's Ain Shams Medical Week named towards the access to innovation. We have participating departments, 10 academic and 20 clinical, esteemed 25 guest speakers over 7 working days. We have also 126 total working hours. On the behalf of the Faculty of Medicine at Ain Shams University, I hope you first best of health in the current COVID pandemic, which despite its negative effects has empowered us to exert more efforts to reach and collaborate with many participants all over the world through webinars, and we are offering free registration to include the maximum number of junior staff all over the world. I'm looking forward to hear feedback from all the participants at the closing ceremony. I would like also to know your conclusions and recommendations. I hope to meet you all next year at the premises of Ain Shams University after the end of this pandemic. Thanks for all of you.
It's a great pleasure to welcome you all in the 41st Annual International Ain Shams University Medical Congress. We prefer to call it Ain Shams Medical Week. I want also to welcome all our guests from abroad who are joining us thanks to the technology and the internet. I'm really grateful to the President of the University, Professor Mahmoud Al-Mitani, and the Dean of the Faculty of Medicine, Professor Ashraf Omar, for their continuous support and encouragement all through the preparations. I want also to thank my colleagues, heads of departments, all the staff, whether seniors and juniors, who put the effort to make the Congress and who prepared the sessions, which I hope to be really fruitful and rich sessions. Thank you to the sponsoring companies who supported the Congress. I have special thanks also to IRIS, the organizing company, Dr. Ashraf Badawi and his team for always being with us in all events. It was really a tough year. 2020 was not a usual year. It was very special. We had lockdowns. We had travel were banned. We had even the gatherings, even the family gatherings were not allowed, which made us all somehow isolated to some extent. So I want to express that I'm really glad that now we have the chance to meet again, even through the internet, but still we can communicate, we can share our experiences. We can introduce our researches, our results, everything that we did this last year. I really wish a fruitful session, a fruitful Congress as a whole, and that each session to have a meaning. Thank you, and wish you all the best.
It's my pleasure to welcome you to the 41st Annual Ain Shams University Medical Congress that will be held between the 21st and 27th of November. There are 10 academic departments and 20 clinical departments participating this year. Because of the COVID crisis, this year is not a face-to-face experience, it's rather a virtual, unique experience that we hope you're going to enjoy. This meeting has 51 CME European credit hours, and there are 126 working hours during these 7 days, and this has been accredited by the European Council for Continuous Medical Education. It's important to know that in this meeting there are 25 international guest speakers, and we hope it's going to be a genuine international experience. I would like to thank the support of the administration, the president of the university, Professor Mahmoud Al-Mitaini, Professor Ashraf Omar, who's the Dean of the Faculty of Medicine, Ain Shams University, Professor Shahira Samir, who is the Vice Dean of Faculty of Medicine, Ain Shams University, for supporting this meeting. As well, I would like to thank all the staff members, coordinators from different departments, and as well Professor Ashraf Badawi and IBIS for organizing this meeting and making this virtual meeting happen. I should not forget also the sponsors of those meetings, because without whom this meeting would not have been held. And I wish you all a very successful and pleasant meeting and pleasant experience with this first virtual Ain Shams University meeting. Thank you.
السلام عليكم جميعا. أنا مش شايفة غير 3
السلام عليكم.
بس الباقي كله بانلست، لكن
Professor Sulaf, the attendees are through the platform, not through Zoom.
محدش دخل خالص.
Professor Sulaf, the attendees are through the platform, not through Zoom.
Oh, okay.
Okay, so please start.
Okay. بسم الله الرحمن الرحيم. On behalf of the head of department, Professor Heba Hassan, I would like to welcome you all in the annual conference of the Pediatric Department at Ain Shams University. I would like to thank you all for being there in spite of the challenges and busy schedule you have. Special thanks to our guest speakers, especially Dr. Mu'min Al-Sayed, for his commitment in spite of his surgery. We hope and wish him a speedy recovery. I would like to thank our dear panelists, our dear professors, Professor Rabah Shawqi, Professor of Pediatrics and Genetics at Ain Shams University. I hope she can join. Professor Aizat Al-Subki, Professor of Medical Genetics at Ain Shams University, Professor Muhammad Al-Sawi, Professor of Medical Genetics at Ain Shams University, and Professor Muhammad Saad, Professor of Medical Genetics at Ain Shams University. I would like to thank also our guest speakers, Professor Dr. Tawhida Yassin, Professor Dr. Ihab Al-Hakim, for sharing with us their experience in Urea Cycle defects management. Just for the attendees, a few housekeeping rules. Please mute yourself during the presentations. You can submit your questions in the Q&A boxes, or if in the chat box, it's okay. And we hope we can answer all questions in the 5 minutes after each speaker. And now Professor Muhammad Sawi will have the floor to present the first speaker, Professor Ola Khalifa. Dr. Muhammad Sawi. Dr. Muhammad, you can unmute yourself.
دكتور محمد، لو انت سمعنا يا دكتور محمد. ميك شور انه الزوم والانترنت عندك كويس وانك سامعنا to introduce the first speaker.
Dr. Muhammad got disconnected. Please proceed.
Disconnected. I feel from his face that he is disconnected.
Yes, sir.
I would like to introduce our first speaker, Assistant Professor Ola Khalifa. She is the Secretary General for the conference. She's Associate Professor and Consultant of Medical Genetic Department, Faculty of Medicine, Ain Shams University. Her talk will be about Urea Cycle Defect clinical spectrum. Please, Ola.
Bismillah ar-Rahman ar-Rahim. Thanks a lot, Professor Sulaf, for your introduction. Today, I had the pleasure to participate in the 41st Annual Ain Shams University Medical Congress and the first international conference of Inborn Errors of Metabolism on an update on urea cycle disorder. My presentation today will be urea cycle disorders, a clinical spectrum. My presentation flow chart will be background, followed by genetics, clinical presentations, and finally conclusions. The urea cycle is a metabolic pathway that transforms nitrogen to urea for excretion from the body. Deficiency of an enzyme in the pathway causes a urea cycle disorder. The urea cycle disorders are carbamyl phosphate synthase 1 deficiency, ornithine transcarbamylase deficiency, argininosuccinic synthase deficiency, this known as classic citrullinemia, argininosuccinate lyase deficiency known as argininosuccinic aciduria, N-acetyl glutamate synthase deficiency known as NAGS deficiency, as well as arginase deficiency known as argininemia. Again, as I wanted to show all of you that the urea cycle is a metabolic pathway for transforms nitrogen to urea for excretion from the body. As we can see here, there is part in the mitochondria and another part in the cytoplasm. In the mitochondria, here there is two enzymatic reaction, and the rest of the reactions are in the cytoplasm. And again, for the elimination here in the form of urea to be water-soluble eliminated from the body. Urea cycle disorders, except for arginase deficiency, results in hyperammonemia and the life-threatening illness. That is to say, in all the forms of the urea cycle disorders, you do have hyperammonemia striking, but the clinical presentations for patients who do have arginase deficiency have a different scenarios from the others. And I'll show you on the next slides. Urea cycle disorders occurs in approximately 1 in 8,200 persons in the United States. And according to Urea Cycle Disorders Consortium on the National Institute of Health of Rare Disease, on a group of patients with urea cycle disorder, they found that about 2/3 of a patient presenting with initial symptoms after the newborn period. What about the genetics of urea cycle disorders? All the urea cycle disorders are autosomal recessive disorders with the exception of OTC deficiency, which is an X-linked. That's to say the recurrent risk for patients or for couples who do have a child with a urea cycle disorder is a 25% in each pregnancy to have an affected child, whether it's a boy or a girl with a urea cycle disorder. The majority of affected patients present in early childhood, though those with partial deficiency may become symptomatic later in childhood. I'm going to say severe enzyme deficiency or complete absence of the enzyme, they do present early in childhood, and those with partial or some residual enzyme activity may become symptomatic later in childhood or as an adult. Frequent vomiting, poor appetite with refusal of food intake, and protein aversion are common features in patients with urea cycle disorder. This is very important for pediatricians and also for healthcare providers to know that if I'm taking during consultation, I'm taking history from the parents to know that those patients, they do have protein aversion, and usually to know that this patient could be prone to urea cycle disorders. What about the typical presentations? We do have two presentations, typical presentation and atypical presentation. Typical presentations, again, for those patients who do have severe defects, they typically present for newborn period after usually 24 to 48 hours after birth. But I want to stop here to say that it is not the general rule for a patients for urea cycle disorders to do have presentations like this, because the delivery of the baby through the birth canal is a stressful condition, and some newborn can do manifest the problem even immediately at birth without taking any protein load. The infant becomes symptomatic after starting feeding, usually as a human milk or that breastfeeding or a special or formula. And again, I said it is not generally the rule, but this is a most common presentation. What about the typical presentations? I want to say also for patients with inborn errors of metabolism and also for a urea cycle disorder, as an example today for our presentation, that there is no specific symptoms or signs to categorize patients with urea cycle disorder. Usually those symptoms, we say that we have a high index of suspicion to think if the baby do have this manifestation, to have index of suspicion. And it's very important, I want to say, when I am going to suspect a baby or a newborn with inborn errors of metabolism, if I do have a newborn who is delivered normally and discharged home and they become readmitted again, say in the first week or 10 days without any surgical cause, or admitted to ICU without any reason, I have to think about inborn errors of metabolism. So here for urea cycle disorders, the typical presentations could be somnolence, poor feeding, vomiting, central hyperventilation. And this central hyperventilation is usually caused by hyperammonemia with its effect on brainstem with the resulting respiratory alkalosis. But some patients, they don't have respiratory alkalosis. Absence of respiratory alkalosis does not rule out a urea cycle disorder. For also the 50% of newborn who do have severe hyperammonemia, they do have seizure without any overt clinical manifestations, and if left untreated, it can proceed to coma and finally death. Affected patients have a lifelong risk of metabolic decompensation with intercurrent hyperammonemia. That's to say, when, say, a newborn have a presentation early, first 10 days or 7 days, this is an initial presentation. But when I wanted to say, or when I want to alert the family about another attack, usually in the second half of the first year, at approximately around 6 months of age, when the baby started to have weaning and the mother did not acquainted about the calculation of the solid food with the protein amount, those patients are liable to have metabolic decompensation. Another thing is metabolic compensation also occur when there is increased catabolism, when there is infection, fasting, surgery, or trauma. So it is a very important message to tell that there must be an emergency protocol, what will be mentioned in the coming presentations, that it should be supplied to the parents or to the family, and to know that their children are prone to have another problem, and to guard against this manifestation. On the other hand, there is patients with atypical presentation. Patients who do have a partial enzyme deficiency have atypical presentations after the newborn period. Despite they are lucky, they do have the manifestations after a newborn period, which can be postponed up to adult. The first metabolic decompensation with hyperammonemia can be so severe that those patients can have a fatal attack if no diagnosis has been made. So very important to be cautious and to have a high index of suspicion again of this scenario, just to help for early diagnosis and better prognosis for those patients. The example of those with atypical presentations are patients with OTC deficiency, such as female with OTC deficiency. It was found that 15% of females with OTC deficiency, they do have hyperammonemia during their life, which necessitates to have a chronic hyperammonemia management. On the other hand, recent publications, they found that those patients, if they don't have overt hyperammonemia, they do have some executive problems. But I don't to say that only O2C deficiency patients, they do have partial enzyme deficiency. Any one of the urea cycle disorders enzyme, they can do have partial enzyme deficiency also. What about the presentation of those group? Chronic vomiting, developmental delay, seizure disorder, sleep disorder, psychiatric illness. Some patients do have a headache, lethargy, ataxia. These patients tend to prefer vegetarian diet because dietary protein intake often is associated with headache. Usually, again, if I do have a scenario or take history from parents, I have to be cautious about this presentation, to think again about a typical presentation. Hyperammonemia may be chronic or occur during metabolic decompensation, but it is less severe and may be more subtle. It is important to consider a urea cycle disorder in a patient with recurrent metabolic decompensation, and the clever clinician or physician is the one who pick those patients during attack, because those patients usually do have normal ammonia level in between attack. So it's very important. As symptoms of urea cycle are non-specific, the manifestations of ammonia-triggered encephalopathy should be immediately suspected for any patient with urea cycle disorder. Patients, on the other hand, with deficiency typically present later in life to preschool age, and the most important manifestations is spasticity. As I said in my first slides, those patients are missed as cerebral palsy. Again, we have to think good on those group of patients. Other presenting symptoms are similar to those with partial urea cycle disorder. In conclusion, the urea cycle disorders, the metabolic pathway that transforms nitrogen to urea for excretion from the body. Urea cycle disorders are caused by inherited deficiency of an enzyme in the pathway. Urea cycle disorders, for example, CBS1, OTC, SS, SL, NAGS deficiency, and arginase deficiency are classic examples. Urea cycle disorders should be immediately suspected when unexplained encephalopathy occurs at any age, but particularly in neonates. Urea cycle disorders, again, except for arginase deficiency, result in hyperammonemia and life-threatening metabolic decompensation in infancy. So all of us has to be cautious about that. The take-home message, I want to say that prompt recognition and the treatment are important to improve outcome. Thank you.
Thank you, Dr. Ola, for this presentation. And you were in time, just on time. I don't see any question for you in the next session. Would you like to present the second speaker?
The second speaker will be Professor Johan Happerly. He is a senior metabolic consultant and the head of metabolic laboratory, University Children's Hospital, Zurich, Switzerland. And he is going to present a biochemical and molecular diagnosis of urea cycle disorder. And again, I want to thank Professor Happerly because despite he had a commitment which was planned before, since our conference plan, he did a recorded lecture for his presentation, but he will shortly join us at the end, not after his session, for Q&A. So please, for the video.
So good afternoon, everybody. It is my great pleasure to be part of this conference. My name is Johannes Heberle. I'm a pediatric consultant working in Zurich, Switzerland. And I would have loved to be on the spot, but now I'm also glad to give you my presentation online. I will be talking about biochemical and molecular diagnosis of UCDs. And my talk and the content of my talk really is based on an article that we published last year in the Journal of Inherited Metabolic Disease, where we describe in detail the diagnosis and the therapeutic management of patients with urea cycle disorders. So if you're interested in certain aspects of my talk, you can go to that article, which is freely available online, and read it there. Now, we have heard about the urea cycle today, and you will in other talks later in the afternoon also hear about the urea cycle. Here is an image of the urea cycle in which you see the mitochondrion and in which you see some of the enzymes and transporters as well as metabolites of the urea cycle depicted. On the right panel, you see a list of biochemical and molecular approaches to diagnose a urea cycle patient. And of course, you find there ammonia. And of course, you find there orotic acid. And of course, there's amino acids. But there's also enzyme analysis, and there's newborn screening. And I will briefly talk about a method that we developed in Zurich and that is in general usable and useful for the diagnosis of urea cycle patients, which is stable isotope-based ureogenesis analysis, and I will come to that later. And in a second, shorter part of my talk, I will be talking about molecular genetic diagnostics, and we will look into the different methods that are available, and I will propose an algorithm to do mutation analysis for urea cycle defects. Now, if we talk about the diagnosis of urea cycle patients, we should realize really that there is a link between the diagnosis and the outcome of patients. We did a few years ago a study in which we looked into the relation between the time when the diagnosis was made after the onset of first symptoms and the outcome of a patient. And we found a striking relation. And this is depicted on this graph. Here you see the results from 91 patients, and you see in single dots, single patients. Now, on average, in those 91 patients with urea cycle defects, there was a delay of 1.6 years to make the diagnosis. I have to add that those were late onset patients, but as we all know, half of the patients are in fact late onset patients. So they had an average delay of 1.6 years. If the delay was less than a year, 46% of those patients had a cognitive impairment. In contrast, if the delay was more than a year, 75% of those patients had a cognitive impairment. And that shows the relationship that underlines why diagnosing a patient early and precise is important also for the clinical course and the outcome, the prognosis of the patient. Now I will start with a few words now on ammonia. Plasma ammonia is the mainstay of identifying a patient with a urea cycle defect. And I just want to remind ourselves that we all should consider plasma ammonia determination in every patient that has an unexplained encephalopathy, that has a suspected intoxication, and also we should consider it in patients with a suspected neonatal sepsis, because that can mimic a hyperammonemic crisis. Now, a few words to analytical and pre-analytical aspects. If we want to determine ammonia precisely, we should collect free-flowing blood. We should transport the blood sample in ice water to avoid hemolysis of the sample, and we should ensure a fast analysis of the sample and also a fast reporting of the results. So the lab should have a close link to the doctors and physicians on the ward to back report the result as soon as possible. Now imagine a patient has been diagnosed with elevated ammonia. Then really you only need few tests that are guiding you towards diagnosis of a false increased ammonia or a inborn error of metabolism. And those tests include some bedside tests, that is glucose and lactate and blood gases. And in addition to that, you only need electrolytes and carnitine and the transaminases and possibly the coagulation parameters. But from a metabolic point of view, you only need a lithium heparin sample for amino acid analysis. You need a urine sample, a spot urine sample for analysis of organic acids and of purines and pyrimidines, which includes the measurement and analysis of orotic acid. And you need dried blood spot or full blood for the analysis of acylcarnitines. And with those three samples, a heparin blood sample, urine, and a dried blood spot sample, and those few tests, amino acids, organic acids, pyrimidines, and acylcarnitines, you can diagnose most of the patients that have an elevated ammonia. At least you can get to a suspicion diagnosis. You can narrow it down to either urea cycle defect or fatty acid oxidation defect or an organic aciduria or a more rare disease. And if you have those tests done, you can look, for instance, in the guidelines that I mentioned in the beginning, and you can use an algorithm. Here we propose an algorithm for the workup of hyperammonemia, and you see that we first look at the levels of glutamine, and from there work our path together with the organic acid results, together with the citrulline quantification to any of those different differential diagnoses. Now, to confirm a diagnosis of a urea cycle defect, you have different possibilities. One possibility is to look purely at the metabolites. Those that I mentioned before, the amino acids, together with orotic acid from urine, possibly the organic acids in urine. And then metabolites are often indicative for a UCD. Rarely they are specific and diagnostic and confirmatory. An example for such a confirmatory metabolite would be the presence of argininosuccinic acid. If you find argininosuccinic acid elevated in blood or in urine, this is a strong indication and almost a confirmation of ASL deficiency, argininosuccinic lyase deficiency. Likewise, if you find a very high citrulline in plasma, that is more than 1,500 micromoles per liter in a patient, this is strongly suggesting citrullinemia type 1 ASS deficiency. But other than those two examples, I would be very hesitant to rely a diagnosis only on metabolites. Possibly another example could be the presence of homocitrulline. That could be indicative, strongly suggestive for triple H syndrome. More often you will need some other confirmatory means, and that could include enzyme analysis, which in principle is feasible for all urea cycle defects, but you need specialized tests. For most of the enzyme analysis tests for urea cycle disorders, you need a specialized laboratory. You often need liver tissue. You may, for some of the urea cycle disorders, rely on fibroblasts, but this is invasive and this is specialized and not widely available. There's one exception, which is arginase deficiency, hyperargininemia, in which it is relatively straightforward to do enzyme analysis by using red blood cells. However, more often nowadays, people use mutation analysis for the confirmation of a urea cycle defect. Mutation analysis nowadays clearly is the method of choice to confirm a urea cycle defect. It's more and more available. It allows genetic counseling. It allows prenatal diagnostics. So it has several advantages, and we will talk about that in just a minute. Now, something that is not very much available, not widely available, is newborn screening. And I will briefly discuss the history and current status of newborn screening for urea cycle defects. Already in the 1970s and 1980s, several countries used urine chromatography methods for detecting metabolites from mainly the cytosolic urea cycle defects. In Austria, but also in some states of the US and New Zealand, for instance, also newborn screening programs using enzyme multiple auxotroph screening in dry blood spots were initiated already back in the 70s and 80s. Most of these programs were stopped after a couple of years for different reasons, low sensitivity, not high enough specificity, etc. Since 1998, after the introduction of the mass spectrometry method, some countries are using this method, MSMS, for detection of the cytosolic urea cycle defects in newborn screening, and later when the MSMS screening became widely available in newborn screening all over the world, an increasing number of states now using MSMS, mainly for the cytosolic urea cycle defects, so ASL deficiency, ASS deficiency, and hyperarginemia, but less so for the proximal urea cycle defects. And that has several reasons. One reason is that the detection of glutamine from dry blood spots is not easy technically. And another reason is that citrulline, which is another marker that would be very useful for the proximal urea cycle defects, that is the mitochondrial urea cycle defects, OTC deficiency, NAGS deficiency, CPS1 deficiency. But citrulline has some problems in itself. So in general, for proximal urea cycle defects, a combination of markers is required. Low citrulline levels, which would be the marker for the proximal urea cycle defects, are also found in patients that have a protein restriction, in patients with certain intestinal pathologies, for instance, short bowel syndrome or some severe infection, but also in mitochondrial disorders, you may have a low citrulline, and in premature babies. So one prominent project to overcome the technical problems of the low sensitivity of detecting proximal urea cycle defects in newborn screening is the Region 4 STORK project, in which several amino acids are quantified: citrulline, arginine, alanine, methionine, phenylalanine, glutamine, and several ratios are built from those metabolites. And with that project and with that algorithm and approach, proximal urea cycle defects may also become a feasible target for newborn screening, which would be, of course, nice. The current status of newborn screening for the proximal urea cycle defects, here depicted for the US, you can see that some states in the US have now included CPS1 deficiency. It's even required by law to screen for CPS1 deficiency in some of the countries. But this is something that needs to become more widely available, more widespread, before we can really judge on the newborn screening. I will now spend a few words on a method that may be new for you. You may be unfamiliar with that method, and that is the use of stable isotopes. Stable isotopes can be utilized to analyze the entire flux through the urea cycle. We've so far talked about enzyme analysis, or we talked about metabolites of intermediary metabolites of the urea cycle and their quantification. The analysis of ureogenesis using stable isotopes is a method in which the entire flux of the urea cycle can be quantified. Here you see the normal situation. The natural source is 14N as part of ammonia, and that goes through the urea cycle, arriving in urea. Now, you can use a tracer with a label, a non-toxic label, a stable isotope 15N. Ammonium chloride can be given at a very low dose to a patient or a proband. And if you give this tracer to the patient, this label will go through the urea cycle and will end up in urea by labeling urea. And this label can be detected because it causes a slight difference in mass. So a urea molecule that carries this 15N label has a different mass and can be separated from the natural source, the natural urea. We've started investigating that in patients, in several urea cycle patients, and we, using this method, can distinguish the very severe patients, neonatal onset patients, from the patients with a milder defect, for instance, the heterozygous OTC females. But we also see differences in patients that get citrulline or arginine to stimulate urea cycle function. We see, of course, a huge difference if you do the test before or after liver transplantation. And we can use the test also to test different treatment protocols. So this is something you should bear in mind nowadays more for research projects, but soon hopefully also for clinical practice in case you are interested in the overall ureogenesis capacity of the urea cycle. I will now, for the last few minutes of my talk, consider mutation analysis. Mutation analysis, I mentioned before, is the method of choice to confirm a urea cycle defect. It's feasible for all urea cycle defects. It requires analysis of DNA, which you can get from blood cells, also from fibroblasts, from dried blood spots. And you can use the different methods. I will briefly discuss that later on. You can use next generation sequencing. It has some limitations because you need to know the coverage of the next generation sequencing. And you can also do RNA sequencing, which is an additional tool and helpful for certain patients in which DNA sequencing did not result in a mutation. And you should bear in mind to include promoter and or regulatory elements, because we now realize that more and more patients are found that carry a mutation in their regulatory domains. With standard methods, nowadays about 80 to 90% of the urea cycle patients can be detected, can be confirmed. And that means that there's a small proportion of the patients in which you need to address other methods, more specialized methods. And the algorithm that we are using in our lab is the following. If we receive a sample, we extract DNA, and then we consider the clinical situation. If it is urgent and or if there is a clear suspicion for a certain urea cycle defect, we perform a single gene analysis, a Sanger sequencing method, because that is fast and easy and relatively straightforward. In all other situations, either if it is not urgent or if there's no clear suspicion, if you don't really know whether it's a proximal or a distal urea cycle defect, we would nowadays perform panel sequencing or whole exome sequencing. So we would use a next generation sequencing method. And that, as I mentioned, results in 80 to 90% of the later confirmed patients in a mutation. Now, if that approach does not result in a mutation, we would go one step further in case the patient indeed has a strong suspicion for a urea cycle defect. So we would add MLPA, or we would add RNA sequencing, promoter, and regulatory sequencing. And that depends then, of course, on the situation. Mutation analysis has several advantages. It provides often a definite diagnosis. It is sometimes predictive for the prognosis, and you can use electronic tools for that, in silico tools. It allows family counseling, which is extremely important, I think. It offers the option of prenatal testing if the family would consider that. It is now widely available, and the costs have dramatically decreased over the past years. Here's an example from the American Journal of Medical Genetics, in which an OTC family was investigated following the diagnosis in a 5-year-old or 8-year-old child, in which then the members of the family over 4 generations were identified to be a carrier or affected. So in summary, biochemical assays, of course, are the mainstay for the initial diagnostics of urea cycle patients. Most important are ammonia, amino acids, and orotic acid, analysis, but specialized assays, either the enzymatic analysis or, mentioned by me, stable isotope assays, are available now in a few centers. Mutation analysis clearly is the preferred method to confirm the diagnosis of UCD because, and I mentioned that a second time, the comprehensive family counseling does require a mutation analysis. With that, I finish and thank you for your attention.
I'd like to thank Professor Happerly, despite he is not online for his presentation, but he will join shortly afterward at the end of the session. So if you kindly, Professor Sulaf, you can introduce the next speaker.
It's our pleasure to have Dr. Ain Shams with us today in spite of his surgery and fracture a couple of days ago. He's a professor of genetics, College of Medicine, Al Faisal University, a director of genetic counseling program, and the chairman of Department of Medical Genetics, King Faisal Special Hospital and Research Center, Riyadh, Saudi Arabia. The floor of yours, Dr. Ain.
Assalamu alaikum wa rahmatullahi wa barakatuh. First of all, I would like to thank the organizers. I would like to thank Professor Ola for the kind invitation. And I'm very glad always to be with my colleagues in the region and especially in Egypt. And the task that Dr. Ola has asked me to present is management of urea cycle disorders and update. The main points that I'm going to address in my talk includes very brief idea and introduction about the urea cycle disorders, clinical groups, incidence. Much of this is already mentioned by Dr. Ola. The definition of hyperammonemia, measuring ammonia, and differential diagnoses of hyperammonemia. The treatment.
Doctor, can you please close your presenter view?
Can you see my slides?
Yes, we can see the presenter view. Can you please close it?
Presenter view? What do you mean by presenter view? Is that okay now?
Can you press swap displays, the button on the up?
Okay.
Doctor, please press use slideshow on uplift.
One second. Let me. How about if I try to share it one more time?
Doctor, there is a button in upper left corner. Can you please?
Okay. Can you see these slides now?
Yes, doctor. Please make it full screen.
Is that okay now?
No.
Please press use slideshow on the upper left.
Oh.
Instead of end show, press use slideshow.
Okay. Slideshow. Okay. It should work now, I hope. Is that okay now?
Yeah.
Are we okay? All right. So treatment principles, methods of dialysis, medications in UCD, transplant versus medical management. Now, some of the treatment strategies I have to stress that are presented are those of my own experience in my center, and there is considerable variation in clinical practice when it comes to rare genetic diseases, as you all know. So briefly talking about the urea cycle. Urea cycle was described by this gentleman, Hans Krebs, in 1923. And the urea cycle main function is in the liver, and it is to convert the toxic ammonia to urea. There are 6 primary genetic urea cycle disorders and 3 additional disorders that are in the broader spectrum of urea cycle. So if we look at this diagram, this is the urea. The urea is made of 2 molars of nitrogen. One is coming from the nitrogen on the top that is donated from glutamine, and the other one is coming from aspartate. There are 3 mitochondrial urea cycle disorders, including NAGS deficiency, CPS1, and OTC deficiency. There are another 3 primary urea cycle disorders, ASS causing citrullinemia, argininosuccinate lyase deficiency causing argininosuccinic aciduria, and arginase 1 deficiency causing arginase deficiency. So these are the 6 primary urea cycle disorders. In addition, there are transporter defects. This is citrin as well as ornithine transporter defects. The main function of the urea cycle includes clearance of ammonia, the majority of which takes place in the liver, the production of urea, which is a concentrating agent in the urine, the production of arginine, the production of citrulline, and the production of nitric oxide. If we look at the urea cycle in the liver, it is a high capacity, low affinity system. And in the liver, the urea cycle is mainly used to detoxify the body from excessive nitrogen by producing urea. There is less production of citrulline, arginine, as well as nitric oxide. So the bulk nitrogen is converted to urea in the liver, and there is a small amount of nitric oxide produced through the urea cycle. If we look at the intestine, which is the other place where the urea cycle exists in abundance, the function of the urea cycle here is different. The urea cycle here is more involved in the production of citrulline and arginine and nitric oxide, and less in the production of urea. The urea cycle disorders can be divided into proximal urea cycle blocks, and these are intramitochondrial enzyme deficiencies. They are expressed only in the liver and intestine. This is the NAGS deficiency, CPS1 deficiency, OTC deficiency. Then we have the distal urea cycle blocks, which are the extra mitochondrial, and they are present in all tissues. This is the citrullinemia, argininosuccinic aciduria, argininemia. In addition to this, we have broader urea cycle disorders, which are the transporter deficiency, the ornithine transporter, causing HHH syndrome, the citrin deficiency causing type 2 citrullinemia, which is a malate aspartate shuttle imbalance, and lysine protein intolerance, as well as pyrroline 5-carboxylate synthase deficiency. So the most important of these that, as Dr. Ola has mentioned, that present really with severe hyperammonemia, about 50% of these 5 disorders depicted in red present in newborn period with hyperammonemia. There are certain very important facts. All urea cycle disorders are autosomal recessive, except OTC, and heterozygous females do manifest the disease. All have early neonatal onset and late onset. The late onset, as stated earlier, can present with bizarre symptoms of loss of appetite, cyclic vomiting, lethargy after meals, psychiatric and behavioral changes, and usually are caused by partial defect. One of the hallmark of urea cycle disorders is low urea and respiratory alkalosis when these patients present with hyperammonemia. The overall incidence is thought to be anywhere between 1 to about 1 in 35,000 newborns, and every year approximately 150 cases are diagnosed in Europe and 2,000 cases are diagnosed in the USA. This is a publication showing the different types of urea cycle disorders recorded in several different registries. And as you can see, the overall incidence is 1 in 35,000, but in the Western population, the OTC deficiency appears to be more readily diagnosed with an incidence of about 1 in 56,000, followed by ASL and ASS deficiency. Comparing to our situation in the Kingdom of Saudi Arabia, since we have newborn screening for several urea cycle disorders, we have the incidence of argininosuccinic aciduria 1 in 16, almost 17,000, compared to 1 in 250 to 550,000 in the US. So it is at least 15 to 33 times higher. And I suspect that the incidence in Egypt will also be higher than many other places in the world. Similarly, if we look at citrullinemia, we are approximately 10 times higher incidence than what is reported in the United States. Several clinical centers that deal with urea cycle like to group them into several groups based on the presentation. So group 1 are the CPS1 deficiency and OTC deficiency, and these patients present within the first few weeks of life with little enzyme function. They have severe disease. They have inability to produce citrulline and hence arginine. There is fragility to catabolism, so they decompensate if there is any catabolism, sensitive to environmental stress like infection, drugs, dehydration, and delivery. And here in the management, typically citrulline is used more so than arginine. The second group are the argininosuccinic acid synthase deficiency and lyase deficiency. These are the early onset, presenting similarly like group 1. And here we are unable to produce arginine in particular. And there is the ability to use citrulline for partial scavenging of nitrogen. And again, these patients will present with any decompensation caused by intercurrent illnesses. The third group are the late and the atypical onset, and all urea cycle disorders can present with this presentation due to partial enzyme deficiency. So they typically do not have early onset hyperammonemia. They have abnormal amino acids, if you test their amino acid profile. And the hallmark here, the differentiation comes from measurement of argininosuccinic acid and orotic acid, which is elevated in OTC deficiency, but not so in CPS deficiency. And argininosuccinic acid is the hallmark of argininosuccinic acid lyase deficiency. Mild elevations of ammonia in the late form and atypical presentation, as we have mentioned, and again, severe hyperammonemia can develop under stress. The fourth group is the NAGS deficiency, which actually can present at any age. And these patients can be easily treated with carbaglumic acid, which is an analog of NAG, and they will have normal biochemical behavior and may have normal development if they are caught early and started on treatment. The group 5, which stands alone, are the OTC carrier females, and these carrier females will not typically have hyperammonemia unless they come in with decompensation. And care should be given during pregnancy. They may not have any amino acid disturbance, and they may have also normal intellectual function depending on the severity of the disorder. The group 6 groups the arginase deficiency, the triple H, and citrin deficiency all together in one group. So moving on to the next part of my talk, how do we define hyperammonemia? Most studies define it with less than 38 micromoles to 57 micromoles per liter, except in the newborn, where we could accept up to 110 micromoles per liter. There are values for adult male and females that are slightly different, but not clinically significantly different. However, any hyperammonemia has to be correlated with the presence of clinical symptoms and signs. The typical clinical symptoms and signs of hyperammonemic toxicity are lethargy. Patient and the newborn or the child will need stimulation to feed, may have nausea and vomiting, hyperventilation, abnormal movement, and coma. There are 2 units used in measurement of ammonia. There is the micromole and the microgram. And the conversion from micromole to microgram is a multiplication by 0.59. So this could be useful for some of you who use either of these 2 units. The ammonia measurement can be very tricky. It has to be in heparinized tube, EDTA tube, which has to be chilled. There should be minimal muscle manipulation with meals, and there is variation with meals. Therefore, fasting ammonia is the best measurement that can be done. Immediate placement on ice, plasma. In plasma, the ammonia is stable for about 15 minutes and for 4 hours under 4 degrees centigrade, and for 24 hours under -20 degrees centigrade. Whole blood ammonia level are stable for less than 1 hour at 4 degrees centigrade. There are several other new inborn errors of metabolism that may present with hyperammonemia in the newborn period or later. Just to name some: organic acidureas, fatty acid oxidation defect, glutamine synthase deficiency, and recently carbonic anhydrase type 5A, and other metabolic diseases that cause primary lactic acidosis, pyruvate carboxylase, glutaric aciduria type 2, and a variety of mitochondrial disorders. So, in addition to genetic diseases, other causes are liver insufficiency, valproate therapy, acetaminophen therapy, infections, especially with urease positive bacteria, asparaginase deficiency, and perinatal asphyxia. Now, there is a very crude correlation between ammonia level and symptoms. So typically, if you look at the ammonia level below 35 micromoles or 63 micrograms, this is the normal value. And anywhere up to 60 or 108 is subclinical hyperammonemia. And then after that, you start developing symptoms of hyperammonemia until at a stage of ammonia level where you will end up having hyperammonemic coma. However, this correlation, for those of us who work in inborn errors of metabolism, we know very well that this correlation is not very solid. And patients who are exposed to chronic hyperammonemia may not develop encephalopathy even at higher levels of ammonia. Ammonia is involved in so many different mechanisms, and it affects so many different functions in the body, and therefore hyperammonemia is an emergency and is associated with neurological symptoms and signs with encephalopathy and coma. Another important point to point out is the importance of glutamine. Glutamine is produced in astrocytes from glutamate, which is released from the nerve cell ends. Excess glutamine synthesis causes, so if you have too much glutamine formed, which happens in urea cycle disorder, or accumulation, causes osmotic stress to astrocytes and subsequent neuronal dysfunction and brain edema. And this is what we see in patients with prolonged hyperammonemia. High glutamine level in a patient with urea cycle disorder suggests poor metabolic control, suboptimal ammonia removal, and the need to adjust the treatment. This is a study looking at the MRI of patients with urea cycle disorders in the green here, and those with normal, who are normal. And there is a significant difference in the areas of activation as measured by blood flow compared with in urea cycle patients versus normal control. So there is a reduction in the blood flow in many critical areas in patients with urea cycle disorders when they are performing a cognitive task compared to their normal counterparts. And there are white matter changes that are present and are well documented in recurrent hyperammonemia related to urea cycle. Now, moving to principles of emergency management of hyperammonemia. Now, the most important thing is physical removal of the ammonia by dialysis or some form of hemofiltration, pharmacological scavenging of excess nitrogen, and reversal of the catabolic state through caloric supplementation, and in some cases hormonal suppression using glucose and insulin drip. Important points in the management: aggressive early management should be the rule. You have to secure an IV, hydration, acid-base balance should be maintained. Initially, the patient should be MPO and IV carbohydrates, high dextrose, fat, intralipids, septic workup, prophylactic antibiotics, early ICU admission, and possibly intubation and hyperventilation to prevent the neurological acute damage in hyperammonemia. Transfer to a center with expertise, tertiary care center, after securing above is very important. Dialysis is really the treatment of choice. Hemodialysis followed by hemofiltration, and then the least desirable is peritoneal dialysis. Scavenger drugs should be used. These are phenylacetate and sodium benzoate. Cofactors and resupply replacement drugs like carbo-glumic acid and arginine, and frequent ammonia measurement. Avoiding sodium valproate. Carnitine has no role in urea cycle emergencies. And we should start essential amino acids as soon as possible, 1 to 1.5 gram per kg per day, and increase gradually to boost anabolism. Dextrose, usually we give to provide 6 to 8 milligram per kg per minute. Few comments on the dialysis. So these methods are available. If we look at peritoneal dialysis, usually the clearance is really not great. It's about 3 to 5 ml per minute. And with peritoneal dialysis, initially you cannot feed because you have a peritoneal catheter. There is the infection risk, no vascular insertion, prolonged removal of ammonia. It is cheap, available, and many centers have more experience. Hemofiltration is the second method. Can feed patients who are on hemofiltration, less vascular risk. However, it is catheter size dependent. Hemodialysis remains the choice. However, there is a stop-start problem, and vascular stability and ability to insert catheters differs between different institutes and according to the sickness of the patient. ECMO and hemodialysis combination have also been used, and the advantage with this is that you can switch to filtration. However, these patients may require intubation and oxygen support. The medications that are used in urea cycle disorder, I've listed these medications here with the different product, distributor, manufacturer, and the indication for the use. So the older ones that you are all familiar with is the sodium phenylbutyrate. There are two companies providing this, Horizon Sobi, and then there are two formulations from Horizon Sobi in form of tablets and granules. And there is also Feburane from another company, and that is present in the form of granules, and therefore it cannot be used with NG tubing because it blocks it. And there's also another product by a company by the name of a Special Products, sodium benzoate, sodium phenylbutyrate, and Carbo-Glu by Orphan Europe. The most recent addition to this is the Glycerol Phenylbutyrate. Now, this was approved in 2013, and it has picked up in many centers, especially in the US and in our center, as the main treatment of choice in patients with in chronic management of urea cycle disorder. In addition to this, we also need to use several resupplies and drivers downstream in patients with the different groups. And basically, this is citrulline and arginine. Depending on the type of urea cycle you have, citrulline can be used as well as arginine. Arginine is very, very important in argininosuccinic acid urea and argininosuccinic acid synthase deficiency, as you know. And all patients need to be checked for vitamin deficiency and should be given multivitamins as needed. And amino acids should also be checked, especially the branch chain amino acids, and should be provided if there is deficiency. There are two guidelines. There's an older guideline in 2012, and there was a guideline that was published in the Middle East, which we were part of that publication. And there is a more recent publication that Professor Heberle has mentioned in a few, I guess a year or two ago. And these are very nice, describing in details acute as well as chronic management of patients with hyperammonemia. Few final words about glycerol phenylbutyrate. Now, glycerol phenylbutyrate has a glycerol backbone and has three, instead of the fatty acids, you have three molecules of phenylbutyrate that have replaced the fatty acids. So this molecule requires the pancreatic enzymes to digest. Therefore, patients who have pancreatitis for whatever reason that could be a contraindication to the use of glycerol phenylbutyrate. The mechanism of action of glycerol phenylbutyrate, sodium phenylbutyrate, and sodium benzoate is depicted here. So if we look at glycerol phenylbutyrate, the concept is that this is a fatty molecule, and therefore it is a slow release inside the intestine, and it is digested by pancreatic lipases. It is converted, as well as the sodium phenylbutyrate. Both of them are converted to the active compound in the liver, which is phenylacetate. Now, this is the rate limiting step here, which is the conversion to phenylacetate. Phenylacetate combines glutamine, which has 2 molecules of nitrogen, and it is excreted as phenylacetylglutamine. So this is what scavenging means, you know, as scavenger agents to remove excess nitrogen. So we have the GPB, glycerol phenylbutyrate, the sodium phenylbutyrate, and when it comes to sodium benzoate, benzoate combines with glycine, which only has 1 molar of nitrogen, and it forms hippuric acid. So this is the mechanism of the of detoxification from excess nitrogen. The sodium phenyl, the glycerol phenylbutyrate is absorbed 75% more slowly when delivered as glycerol phenylbutyrate, and therefore it's like a long, you know, acting ammonia scavenger. All right. Now, comparing these 3 molecules, benzoate versus sodium phenylbutyrate versus glycerol phenylbutyrate, benzoate is cheap, it is readily available, it mixes pretty well, hippurate is readily cleared, it's a single nitrogen, and glycine, unfortunately, is not a nitrogen reservoir. So in principle, in theory, benzoate is less effective than the other 2 molecules. Sodium phenylbutyrate is not cheap, it is less available, it has double nitrogen, but now we have generic forms of this medication. Glutamine is a nitrogen reservoir and may be significant part of toxicity, and therefore removal of glutamine is an added value using sodium phenylbutyrate and glycerol phenylbutyrate. The neurotoxicity is a problem with sodium phenylbutyrate, and renal toxicity is a problem with benzoate. Glycerol phenylbutyrate, on the other hand, it is really a remarkable molecule. It is odorless. It is very expensive, unfortunately. It mixes very well. It's nearly tasteless. The amount that is used is really very small and can be taken by mouth with meals. Finally, a word about carboglumic acid use in urea cycle defect. Carboglumic acid is a synthetic analog of N-acetylglutamine. N-acetylglutamine is an activator of the CPS1 enzyme. So if you have NAGS deficiency, or if you have organic acidureas that also inhibit NAGS, you will have a reduction in the amount of natural N-acetylglutamine. So which will have secondary deficiency or cause secondary deficiency of CPS1. Giving carboglumic acid is going to overcome this functional deficiency of CPS1. So it's basically an allosteric activator of CPS1, and it is life-saving in NAGS. And if these patients are caught earlier before hyperammonemia, it's a very, very rare disorder. They can live a normal life using carboglumic acid, and it can also be used in partial CPS1 defects. This is one of the original studies using phenylbutyric acid compared to glycerol phenylbutyrate. And as you can see, the 24-hour excretion of phenyl glycerol is much more steady, which is the blue line, using the glycerol phenylbutyrate, and also the ammonia level is similarly has a much more steady sort of control using glycerol phenylbutyrate, and it is below the normal value. So let me just share with you one of my patients who is now 19 years old. She was first seen many years ago in our facility, coming with hyperammonemia, eventually diagnosed with ornithine transcarbamylase deficiency. And this patient went on the low protein diet, sodium benzoate, sodium phenylbutyrate, and as you can see, with the use of sodium phenylbutyrate, she continued to have multiple episodes of hyperammonemia in spite of maximal therapy. Years later, when glycerol phenylbutyrate became available, we started this patient on this medication, and to our surprise, and fortunately for the patient, the amount of hyperammonemic crisis dropped significantly, and the patient, ER visits declined sharply. So also, if you look at the glutamine value, which I always recommend a constant measurement of glutamine, because it is a parameter of good long-term metabolic control in urea cycle. You can see the patient while on sodium phenylbutyrate, she had values of glutamine that were higher than when we started her on glycerol phenylbutyrate, indicating better overall long-term control of her condition. My final few slides are, I'm going to just give you a brief idea about our experience with pediatric liver transplant for metabolic diseases. This is relatively old data. We are collecting the next 3 years from 2017 to 2020. But during this period, we transplanted 37 patients with various metabolic disorders in our institute. And among those, we had several urea cycle disorders, mostly argininosuccinic aciduria, because this is the most common urea cycle that we see. All our patients with lyase deficiency have been stable. All patients transplanted with citrullinemia were stable several years after transplant. We had one patient transplanted with CPS1 who is also doing quite well. So both parental as well as physician satisfaction has been great. So in summary, our experience and experience of some of my colleagues in the US, I've summarized it here: transplant versus medical therapy only. So the survival with the transplant now is over 95%. Now, you know that in our part of the world, we are able to get partial transplant from a living donor because of multiple siblings and other family members that can donate the liver. We are not curing the disease. We are just trading. Transplant is a trade of one disease with the other. It's not a complete cure. Hyperammonemia goes to zero. Diet is normalized. The subjective improvement in life, most of my patients, the family tells us that they are just more alert, they are more active, they are more attentive, and the IQ stabilizes even in those who had relatively low IQ. There is, of course, the risk of long-term malignancy, infection, myeloproliferation, fertility issues related to transplant, the risk for the donor, and the issue of organ long-term survival, where the jury is out of how long the transplanted liver is going to survive in the pediatric patients. We also need to remember that citrullinemia and argininosuccinic aciduria have extrahepatic manifestations. And therefore, we have to be careful when we are transplanting these patients because the extrahepatic manifestations are not corrected. So the CNS disease and the excretion of argininosuccinic acid from other tissues. Also, we need to supplement these two, citrullinemia and ASA, with cycle intermediates like arginine, and this will continue with the patients post-transplant. Medical therapy only, survival statistics for 5 years are closer to 60%. The risk of brain damage with hyperammonemic events is always there, and it's unpredictable. There is no immunosuppression, no surgery. There is dietary restriction for life. These patients often have, because of that, growth delay and nutritional deficiencies. Final message, hyperammonemia is a metabolic emergency, and deep coma and even death, of course, can happen if it is not treated. And if patients do survive the ammonia, if it is over 1,000 micromoles per liter, it is an indicator of poor outcome. Prolonged hyperammonemia of more than 24 hours to 48 hours is a better predictor of poor outcome, especially CNS. 50% of neonates with hyperammonemia will have seizures, which is also another indicator of poor outcome. This is the patient that I showed you earlier in the initial stage, very severe brain edema on imaging of the brain. And then later on, with this severe hyperammonemia, which was in the range of 2,000, there is absolute brain atrophy with volume loss and ventricular dilatation. So I will stop here, and I thank you for your listening. And I'll be happy to take any questions now or later on.
Thank you, Dr. Ma'in, for this comprehensive lecture. I have only one question from the audience, where we can find intravenous forms of ammonia scavenger.
So intravenous forms of ammonia scavengers are available through, Sobi is one of the companies in the region that is marketing this medication. It's from a US company called Horizon. And then there is another product also from Special Products from the UK. And that is a cheaper product. It is not a registered product. So there is, of course, some safety concerns, but people have used this product often and have claimed to be safe in the UK and some other countries. So these are the two main sources of getting IV sodium benzoate and sodium phenylbutyrate. And I think they have representatives in many parts of the world, including Egypt, I believe.
Okay. Thank you. Another question from me. If you have a patient with only increased glutamate, nothing more, only global developmental delay and increased glutamate, do you think this is of significance?
Any specific urea cycle?
No, just global developmental delay and increased glutamate.
And has no urea cycle disorder?
No urea cycle disorder.
Hyperammonemia or no hyperammonemia?
No hyperammonemia.
In that case, if there is no hyperammonemia, only the glutamine is increased, it's hard to make a case that you have to rule out certain other diseases. So there are certain diseases that cause glutamine increase, and you have to rule that out of the urea cycle, and you have to correlate whether the intellectual disability may or may not be related to glutamine. And if there is a suspicion that it could be related to glutamine, so protein restriction and to see if that has any effect on the patient neurological well-being would be something to be considered.
Thank you. I have more questions, but I will leave it to the end of the presentations.
Okay.
Thank you. Dr. Ola?
I have the greater opportunity to introduce the next speaker, Mrs. Iman Migdad. She's a senior metabolic dietitian, and really she is one of the eminent dietitian at the King Faisal Specialist Hospital and Research Center. And her presentation will be dietary management of urea cycle disorder. Please, Mrs. Iman.
Thank you, Dr. Ola. Can you see my screen?
Yes, please make it full screen. Yeah, it's okay.
Yeah, okay. Thank you. First of all, I would like to thank Dr. Ola and the organizing committee for giving this opportunity for me to be with you today. So as a beginning, I would like to give you an idea about the number of patients that we are following in our metabolic nutrition clinic at King Faisal Specialist Hospital in Riyadh. We have about one patient who is affected with CBS type 1, 3 patients with OTC deficiency, 5 patients with arginase deficiency, 26 patients who are affected with citrullinemia, and the largest number of patients are affected with arginosuccinic aciduria. What are the aims of the dietary management of urea cycle disorders? A restriction of dietary protein intake so that this will decrease the load in the urea cycle and of course will not contribute to increment in ammonia. And a provision of an adequate energy intake is very crucial in the management of these patients in order to prevent catabolism and enhance anabolism, especially during illness. Prevent metabolic decompensation is very critical also during illness and any type of infections. Promoting normal growth and anabolism, of course, is very important in the dietary management of all inherited metabolic disorders, including urea cycle disorders. And of course, dietary management is combined with a proper medical treatment using the appropriate medications that have been mentioned clearly by Dr. Mu'in. The low protein diet that is used in the dietary management of urea cycle disorders is used as a lifelong treatment because it is believed that a reduction of 0.1 gram per kg per day of protein reduces the nitrogen load on the urea cycle by about 60 milligram per kg per day. And the amount of protein is tailored based on the severity of the disease. In severe defects, we don't have to exceed, or most of the time, we don't exceed the safe level of protein intake that was set by the FEA and the WHO, as the most recent one was published in 2007. Of course, this amount is titrated against the biochemical parameters. In milder defects, sometimes those patients might tolerate higher protein intake. Especially in the neonatal period, these patients might tolerate up to 2.5 gram per kg per day. Safe levels of protein intake that you can see here in this table, as I have mentioned, the most recent one was published in 2007, and the one before was published in 1985, and you can notice that the amount of protein or the safe level intake was less in 2007. As I told you before, most of our patients, especially in the neonatal area, would tolerate much more than the upper
This animated video is about NAC's deficiency and organic the end product, urea. However,
All around the world, there are different practices when it comes to the nutritional management of these disorders. For example, in UK, they are not dependent on the use of essential amino acid supplements, and they mainly depend on the safe level of protein intake for the management of these patients. And this was very clear when they had done a survey, including many centers in UK. In Europe, there is another study that had included about 41 centers with 464 patients who are affected with urea cycle disorders. And this survey also found that there is a large variety when it comes to the dietary management of these patients. For example, in UK and Belgium, they are using the safe level of protein in managing these patients. In other countries, they are dependent in the biochemical parameters like glutamine and ammonia. So you can notice that there is a wide variety in the management of these patients when it comes to diet. At King Faisal Specialist Hospital, or I can say in the Saudi Arabia in general, we are using this table or these guidelines that were published earlier in 1994 by Singh, and it actually dividing the total protein intake into essential amino acid mixture and natural protein. And why we are using this practice? Because actually we are using the essential amino acid mixture in the treatment of all of urea cycle disorders. The protein source in the low protein diet of these patients should mainly come from high biological value protein in order to make sure that these patients are getting all essential and non-essential amino acid needed, but also a variety of low protein, of low biological value protein foods such as starches and legumes should be added to the diet of these patients in order to make sure that they are getting the whole range of amino acids. As I mentioned before, the protein tolerance differs from one patient to another, and this depends on the residual enzyme activity, on the growth rate, age, and sex. For infants, this protein should be provided from breast milk or infant formula. And in older children, of course, this will be provided from food. Protein intake from low biological value protein foods can be measured by using the exchange system. We usually educate our patient about the protein exchange system, how to calculate 1 gram of protein from different foods. And this table is showing one exchange of protein and how much food does it. And for example, for yogurt, only 25 grams of yogurt would provide 1 gram of protein. So you can use this protein exchanges in order to calculate the allowed amount of protein for each patient. It is very important to distribute this daily allowed natural protein intake evenly throughout the day. So we always instruct our patient not to consume the whole amount of allowed protein at once. It should be distributed evenly throughout the day. What about the use of L-amino acid supplements or the special formula in the treatment of these disorders? As I have mentioned before, our practice is to use the L-amino acid supplements or the essential amino acid special formula designed for UCD for all of our patients. There are different brands and different companies. What is the theory behind using a special formula for UCD patients? Because this formula contains only essential amino acids, so there will be limited supply of non-essential amino acids, and by this way, the nitrogen utilization in the synthesis of essential amino acids, of non-essential amino acids, will be higher, and so less nitrogen will be excreted as urea. So the theory behind it is simply to derive the excess nitrogen in the synthesis of non-essential amino acids. Of course, these formulas, if they are designed specially for urea cycle disorders, they will contain all of the other macronutrients like fat, carbohydrates, and protein, or as essential amino acids, plus vitamins and minerals and essential fatty acids. There's only the issue of the taste. Most of these formulas, they don't taste very good, but if the patient is used to the taste since birth, it won't be an issue. There are also different practices when it comes to the use of essential amino acids in the treatment or routine management of patients who are affected with urea cycle disorders. For example, in USA, which is similar to our practice, we are using these essential amino acids from birth, since diagnosis, I mean, with a higher dose ranging from 25% to 50% of the total protein, especially with the severe cases. In UK, as I have mentioned earlier, they don't usually incorporate the essential amino acids mixture in the treatment of their patients, only with very severe cases or during a crisis. And if they use it, it will contribute only to 20 to 30% of the total protein intake. Most of these patients are having many feeding problems like poor variety of food eating, food refusal, protein aversion, frequent vomiting, swallowing difficulties, abnormal eating behavior, which might require at the end to insert a tube for a long-term feeding of these patients. Out of the 85 UCD patients that we are following in our clinic are having GT tubes. When you are having a patient who is dependent on GD feedings, you have to make sure that the formula that is delivered through the tube is a complete formula containing of the UCD special formula with measured amount of standard pediatric or age-appropriate formula in order to provide the required amount of natural protein. And then you will make sure that he is taking enough calories by using other additives like glucose polymers. Of course, adequate fluid and fiber intake is very critical when it comes to patients who are GT dependent for the feeding. As I have mentioned before, you have always to make sure that those patients are receiving enough energy intake in order to prevent catabolism, especially during a crisis. And if these patients are able to take orally, there are two different powders, which are glucose polymers or glucose plus fat powders, free of protein, that can be added to the diet of these patients in order to build up calories. Is breastfeeding possible with patients who are affected with urea cycle disorders? Yes. If you have a mother who is having a child or a baby who is affected with urea cycle disorders and she is willing to breastfeeding is possible. And before diagnosis is confirmed, because breastfeeding would not be enough, the mother would be advised to express her milk, and then when diagnosis is confirmed, she will be able to breastfeed her baby. And how would we calculate the amount of a special formula that this patient has to take before each breastfeeding? The volume of specialized infant formula to be given before breastfeeding equals to the daily fluid requirements minus the volume of breast milk to provide prescribed amount of protein. So you will calculate the amount of protein this patient should be on, and you will convert it into expressed breast milk, and you will minus it from the daily fluid requirements in order to know how much special formula you would give this patient before each breastfeeding. If the mother is not willing to breastfeed or express her breast milk, of course, any standard infant formula can be used and mixed with the special urea cycle formula and given to this patient according to special calculations. Weaning diet, we usually start weaning these patients at around 6 months. Protein-free foods should be introduced first with protein content of less than 0.5 gram of protein per 100 gram. Then after that, each 1 gram of infant formula of protein can be replaced with protein-containing food. Of course, this process is much harder when you have a patient who is breastfeeding. It is much easier when you have a patient who is bottle fed. Nutritional and biochemical monitoring of these patients. Of course, these patients should be followed regularly and routinely in nutrition clinic. You have to monitor their height, weight, all anthropometric measurements. You have to look for any signs and symptoms of nutritional deficiencies like skin changes, hair loss. Here is a picture of one of our patients who came to us with acrodermatitis due to protein deficiency because he has been on low protein diet for a long period of time. What are the most important labs that we look for as metabolic dietitians? The most important labs that we look for in urea cycle disorders are, of course, essential amino acids, and the most important one is glutamine. As Dr. Sayed mentioned, it is the key precursor to rise in ammonia, so we have to make sure that glutamine is maintained below 800 micromole per liter. Also, we have to look at the essential amino acids, especially the branched amino acids, especially with patients who are on phenylbutyrate, because phenylbutyrate is believed to lower the levels of branched chain amino acids. So you have to make sure that these levels are maintained normal. You have to look also at alanine. If alanine is high, it means that these patients are not taking enough energy. Glycine is usually high during a crisis. Also, on annual basis, you have to measure what we call as comprehensive nutritional labs, including different minerals and vitamins, vitamin D, vitamin B12, iron, ferritin, selenium, zinc. They are usually measured on annual basis. And if there is a need to measure it more frequently, we would do that. And according to the results, we might add any multivitamins or mineral supplements to these patients other than the formula. Of course, a frequent monitoring of these patients is very crucial. And pre-albumin is one of the laboratory indicators that we are dependent on our clinic in order to decide if those patients are receiving enough protein or not. Here is a table that shows the suggested action that can be done by the physician and the dietitian depending on ammonia and glutamine level. For the sake of time, I will not go through it in details, but it is very interesting table that shows you on how to manage these patients, either by medication, changing the medication dose, or by changing the protein intake based on glutamine and ammonia level. Of course, there are so many factors that you should consider before doing any changes or modifications in the dietary regimen of these patients. This would include, of course, the growth, the puberty, the compliance with diet and medications. You have to make sure first that they are compliant with the diet and medication before making any changes. They are compliant with the intake of their special formula. Are they using the emergency regimen properly, or they are abusing it? All of these factors should be considered. as I mentioned before, glutamine is very important indicator. It is believed also that glutamine has a role in the decreased appetite of these patients, because it is believed that high glutamine level will increase the influx of tryptophan into the brain, and this will increase serotonin synthesis and will increase satiety. The dietary management of illness, as I have mentioned earlier, it is very important during crisis or during any sickness that these patients are given a very clear dietary regimen prescription. It consists of 2-hourly intake of high energy glucose polymer solution. Of course, if they are able to take anything orally, if they are not able to take any oral solution, they should be seeking the nearest emergency room, providing them with the emergency letter they have, and an IV fluid should be started immediately. These patients will be kept MBO, and then if they are able to take any oral formula, their special formula should be reintroduced, because they contain the essential amino acids no later than 40 hours from being MBO. And this table, which you can find in the EIMD website, is showing the emergency regimen for protein-free feeding in infants and children for urea cycle disorders. It's always advisable also that the IV fluids are accompanied with IV lipids if possible, because this will enhance anabolism and reduce catabolism. There is also interesting in the British Inherited Metabolic Disease Group, there are interesting guidelines about the dietary management of these patients during crisis. So I would advise everybody to visit this website, because these guidelines are very clear and useful. At King Faisal Specialist Hospital also we have developed a special emergency booklet for these patients, in order for these patients to take them to their local hospital in case they need any help. And there is a special part about the dietary emergency regimen for these patients that is attached to this booklet. This slide is also derived from the British Inherited Metabolic Disease Group .org. I have summarized in this flow chart the dietary management of patient who is at risk of hyperammonemia or urea cycle disorder at birth, what to do in each scenario if you have a case like this. This flow chart is very clear, and it summarizes what would you do as a dietitian if you have a baby who is at risk of UCD at birth. I think Dr. Sayed have mentioned the different publications when it comes to guidelines. A few words about liver transplant, and I think also Dr. Sayed have mentioned it clearly, but when it comes to diet, those patients post-liver transplant would not require any protein restriction, and they can be a regular diet, but actually we are facing some problem for them to provide them with enough protein, because they are not used to take the high protein containing food. So in summary, diet plays a major role in the management of urea cycle disorders, and a careful balance between protein malnutrition and metabolic control should be maintained. Continuous monitoring of nutritional and biochemical status is the key, and nutritional needs should be individualized all of the time. Thank you very much.
Thank you, Ms. Iman, for your nice presentation. Actually, I do have there is one question for you. How do we overcome the problem of the taste of essential amino acid formula?
Yes. Actually, if the patient is diagnosed since birth, the taste would not be a problem. But we are facing this problem with patients who are diagnosed late. And sometimes they would accept the taste when it is mixed with the juices, with other allowed drinks. So there are so many tricks and tips to provide for these patients in order to make those mixtures more palatable, let's say.
Okay, thank you. Please, Professor Sulaf, you can introduce the next speaker. Professor Sulaf.
Our next speaker will be the company, the sponsoring company, Orphan Europe.
This animated video.
Is the representative here?
The video will be ready in 1 minute.
Okay.
So
then I have a question.
Good afternoon, everybody. It is my great pleasure
what do you use
to be
instead
part
of
this
glucose polymer?
conference. My name is
If you
Johannes
don't
Heberle.
have glucose
I'm a
polymer,
pediatric
we don't have
consultant
it in
working
Egypt.
in
What do you
Zurich,
use instead?
Switzerland.
There are
would
different
have loved
kinds
to
of
be
glucose polymers and
on the spot.
different companies. If you don't have any glucose polymer, you could use the fat and carbohydrate additives. There are other powders that contain fat and carbohydrate. But if you don't have this as well, in older children, they can still use any high energy food like honey, syrup, that can be added to their formula in order to enhance the taste and increase the calories as well. But for infants, unfortunately, you should have, if you are working in an institution with patients who are affected with inherited metabolic disorders, it is very important to have any type of glucose polymer or an additive in order to increase the calorie intake for these patients, because it is very essential, especially during infancy, because you cannot exceed a certain amount of protein. So the rest of calories should come from an additive.
Can you use glucose, the infusion, as an oral supplement? We don't have glucose polymers in Egypt. We are a specialized institute, but
glucose, like Polycose, Ducal, Mexijol, I'm sure that you have any one of them. None of them?
None of them.
For patients, for example, for endocrine patients, what would you use to prevent hypoglycemia during infancy?
We use cornstarch.
Cornstarch, even with less than 6 months age?
Sometimes, no, cornstarch is usually above 6 months, but sometimes we had to use it before 6 months.
Really? Because they won't tolerate it very much, yes?
Not well absorbed, it's not well digested, but we don't have any other options.
Any other choice, yes. Dr. Ella mentioned before that you have the glucose solution added. You have a solution, a glucose solution, huh? Yes.
I'm telling her about the IV glucose. This is the same. I'm telling you about the same problem.
Yeah. And I have understood from Dr. Ula that it can be used orally, yes? The glucose solution that you have.
We used in one patient, in one of our patients.
Yeah, then
was really cut patient. She was with severe manifestations and hypoglycemia.
Yes, I think, yeah, if it is safe to be used orally, it can be added to the formula.
Okay. Thank you.
There is one question came to you also. Can we use Ducal for this condition? Also came.
Can we use
Can
we use DuCal?
Can we use DuCal for the condition of hypoglycemia? I think we have.
Yes, for DuCal, DuCal actually contains carbohydrate or glucose plus fat. So you can use it for any patient with inherited metabolic disorders in order to increase calories or prevent hypoglycemia, except for patients with long-chain fatty acid oxidation defects, because fat is contraindicated. So be careful not to use it with patients who are having or might be having a long-chain fatty acid disorder defect. But with other...
This is the last question which came to Q&A.
Doctor, the video is ready now.
Okay.
This animated video is about NAGS deficiency and organic acidemias. The three types of organic acidemias we talk about in this animation are isovaleric, methylmalonic, and propionic acidemias. NAGS deficiency and organic acidemias are rare metabolic diseases causing high ammonia levels in the body. High levels of ammonia in the blood are not good for the body. They are toxic, especially for the brain, and therefore the excess of ammonia in the blood needs to be eliminated. In this video, we will explain in a short and simple way, 1. How ammonia is formed in the body. 2. How ammonia is eliminated from the body. 3. What happens with blood ammonia levels in NAGS deficiency and organic acidemias. And 4. How Carbo-Glu decreases ammonia levels in NAGS deficiency and organic acidemias. Carbo-Glu, carglumic acid, is a medicine used to treat hyperammonemia, high blood ammonia levels due to NAGS deficiency, and isovaleric, methylmalonic, and propionic acidemias. In 2003, the EMA approved Carbo-Glu for the treatment of hyperammonemia due to primary NAGS deficiency, and in 2010, the FDA approved Carbo-Glu usage for acute and chronic hyperammonemia due to NAGS deficiency. Quite recently, in 2011, the EMA approved the usage of Carbo-Glu for hyperammonemia due to isovaleric, methylmalonic, and propionic acidemias. Part 1. How ammonia is formed in the body. Ammonia is produced in the body as a result of breaking down or metabolizing proteins. Proteins are found in many different food categories, especially meat, cheese, eggs, and fish. Proteins are taken principally from food and broken down into protein building blocks called amino acids. Through the bloodstream, these amino acids are transferred to the liver. Amino acids are then used to create energy and maintain a healthy body. During this process, the body produces ammonia, and as you already know, high levels of ammonia in blood are not good for the body. The excess of ammonia is toxic, especially for the brain, and therefore is eliminated. Part 2. How ammonia is eliminated from the body. The process by which ammonia is eliminated is named the Urea Cycle. The Urea Cycle involves a number of steps that result in converting ammonia into urea. The urea is then transferred to the kidneys and excreted in the urine. Let's take a closer look at the Urea Cycle. The Urea Cycle takes place inside the liver. The liver is the main ammonia detoxification center in the body. It is like a factory where a number of production steps, one after another, are taken by different workers. They represent enzymes. These enzymes help to transfer the toxic raw material ammonia to the end product, urea. However, the CPS1 enzyme, our first worker, can only be activated by the cofactor NAG, depicted by a key NAG, which is short for the enzyme N-acetylglutamate, is formed out of two other substances, acetyl-CoA and glutamate in the liver, with the help from another worker, NAGS. If CPS1 is activated by NAG, it can start the process of transforming toxic ammonia into urea, which is filtered through the kidneys and excreted in urine. Part 3. What happens with blood ammonia levels in NAGS deficiency and organic acidemias? In NAGS deficiency, the worker NAGS is not activated. NAG is not produced, so CPS1 is not able to start the process to remove the toxic ammonia. The ammonia levels in the blood will go up. What happens with blood ammonia levels in organic acidemias? In isovaleric, methylmalonic and propionic acidemias, toxic metabolites are produced. These specific toxic metabolites block the production of NAG by stealing one compound of the key, the acetyl-CoA part, and/or by attacking the NAGS worker to disable him. Therefore, as in NAGS deficiency, the CPS1 worker won't be able to start the urea cycle to eliminate toxic ammonia due to a lack of NAG. These disorders, NAGS and organic acidemias, will cause an increase of ammonia in the blood to toxic levels, which are dangerous especially for the brain. Part 4. How Carbo-Glu decreases blood ammonia levels in NAGS deficiency and organic acidemias. High levels of ammonia need to be lowered as quickly as possible. If high ammonia levels are caused by NAGS deficiency, isovaleric, methylmalonic and propionic acidemias, these can be lowered by activating the CPS1 enzyme and restoring the urea cycle. Remember, if NAGS, the first worker who compiles the NAG key, is not active, or the toxic metabolites from organic acidemias are present, NAG is not produced, so CPS1 is not able to start the process to remove the toxic ammonia. The most effective way to get CPS1 worker functioning again is to supply it with a substitute for NAG. Carbo-Glu is a compound chemically similar to NAG. In patients with NAGS deficiency and organic acidemias, it has the ability to replace NAG and activate CPS1, the first step of the urea cycle. In this way, it acts like the NAG key, activating the CPS1 worker and so starting up the urea cycle and getting it to function again. As a result, highly toxic ammonia can be converted into urea and eliminated from the body. Carbo-Glu, carglumic acid, is a medicine indicated to treat hyperammonemia, high blood ammonia levels due to NAGS deficiency, isovaleric, methylmalonic, and propionic acidemias. It was approved by the EMA for the treatments of hyperammonemia due to primary NAGS deficiency in 2003, and hyperammonemia due to isovaleric, methylmalonic, and propionic acidemias in 2011. In 2010, it was approved by the FDA for the acute and chronic hyperammonemia due to NAGS deficiency. If you have any questions about NAGS deficiency or Carbo-Glu, please contact Orphan Europe.
It is our pleasure to present the next speaker, my dear Professor Dr. Tawhida Yassin Abdel Ghaffar, a Professor of Pediatric Hepatology and Liver Transplantation at Shams University. She is the editor-in-chief of Liver Journal and the deputy chairman of the Society of Friends of Liver Disease in Arab World. She is the fellow of American Association of the Study of Liver Disease and member of the European Association of Study of Liver Disease. Dr. Tawhida was the leader of the first team for Egyptian liver transplantation and the founder of Ain Shams University Pediatric Endoscopy for management of upper GIT bleeding. Dr. Tawhida.
Thank you, Dr. Saleh, for the kind introduction, and thank you, Ola, and the organizing committee for your kind invitation. It's a pleasure to be with you, and I've learned a lot from the speakers throughout this meeting. Liver transplantation is a procedure which is about 60 years old now, and it has been advocated for chronic liver disease or cirrhosis end-stage liver disease, an accepted treatment for end-stage liver disease. Living-related liver transplantation, a method of liver transplantation, is about 30 years old. And what made it possible to do this type of transplantation, which is actually the only transplantation we're doing in Egypt, is that the liver is divided into 8 segments. Each is functioning as an independent functional unit, having its own blood supply, its own biliary drainage, and its own venous drainage. Another factor is the high regenerative capacity of the liver, through which we can remove a part of the liver from the donor and give it to the recipient, giving the chance for the recipient to have, through regeneration of the liver, the recipient will enlarge his liver volume, as well as the donor, who would also enlarge his liver volume to pre-transplantation levels. Liver transplantation is a very tedious procedure. It needs preparation for the recipient as well as of the donor, good choice of the recipient and good choice of the donor. The operation is a long operation, and the post-transplantation care does not stop. You always have to do care for these patients, whether early on after transplantation or later throughout their life. That's the operation. That's the third child who has undergone the operation in our team. This was in 2001. That's how you put the patient. Then the liver is removed, and you see the diaphragm up there. And then that's the donor's liver, the part of the donor liver which is going to be donated to the recipient is put, is preserved here and carried to the other room where the recipient is being operated upon. Indications for transplantation have been related to the liver disease or its complications, fulminant hepatitis, end-stage progressive liver disease, unresectable tumors, growth failure, and intractable pruritus. But there are always other indications, that is the liver-based metabolic defects. Liver-based metabolic defects, and we mean by liver-based metabolic defects whether they are divided into two groups. A group in which there is a structural liver damage, and another group in which the liver is not affected by the disease, is not affected by the deficient enzyme or the inborn error of metabolism, but the liver is the site of this enzyme, and other systems are affected, but the liver is spared. From the structural liver diseases that we have gotten experience in is the hepatorenal tyrosinemia, Wilson's disease, glycogen storage disease. We don't have alpha-1 antitrypsin actually in Egypt, or we haven't got through an experience with an alpha-1 antitrypsin patient, and the PFICs. On the other hand, these conditions in which there is no structural liver affection, but the liver is the site of the deficient enzyme, the MSUD, the Urea Cycle defects, organic acidemias, homozygous familial hypercholesterolemia, primary oxaluria, the Crigler-Najjar syndrome, and the PQ. For structural liver disease, consideration of transplantation depends on the extent of liver affection, the susceptibility to malignancy, because some of these diseases, especially the tyrosinemia, the patient is highly susceptible to hepatocellular carcinoma. And the extent of extrahepatic involvement, because many of the inborn errors of metabolism affect extrahepatic organs. And if the extrahepatic organ is affected to a degree that affects life, this is going to have its repercussions on this decision to do liver transplantation. Also, the recurrence of the disease, whether the disease is susceptible to recurrence or not. In patients who have an inborn error of metabolism but without structural liver abnormality, we need to know for the need for lifelong restricted diet and special formulas. All this makes us allows us to go through the very tedious process of liver transplantation, because these patients haven't got a liver disease. So why are we going to transplant them? Because most of them need lifelong restricted diet and special formulas. They got life-threatening metabolic crisis, as they mentioned in the Urea Cycle disorders. in spite of treatment in many conditions, the outcome is guarded, especially in the organic acidemias and phenylketonuria. So when considering a transplant for an inborn error of metabolism, we should consider whether the transplantation is going to cure the condition or whether it's going only to ameliorate the condition, meaning we're going to have residual effects of the original condition. The timing of transplantation, choosing the timing of transplantation is crucial and very important because, as I had mentioned before, extrahepatic involvement could preclude transplantation and transplantation at the proper time could save another organ. Careful perioperative management is essential and is necessary, and having the assistance of an inborn error of metabolism specialist is important because many of these have got special needs preoperatively and operatively because of the metabolic decompensation and the catabolic effect of surgical stress. The question of using parents as potential donors is important to answer because we only have the option of living-related liver transplantation in our country. We are going first to talk about hepatorenal tyrosinemia. This is one of the causes of liver indications of liver transplantation in a disease, inborn error of metabolism, that affects the structure of the liver. When are we going to transplant such a patient? What is the indication? If the patient gets fulminant hepatic failure, if he is prone or having HCC, hepatocellular carcinoma, if he is resistant to the drug used in treatment of hepatorenal tyrosinemia, and in our country, we resort to transplantation because of the very high cost and unavailability of NTBC, which is the drug for management of tyrosinemia. These are pictures from our patients. You can see the cirrhotic liver that has been explanted. You can see the nodule, the cirrhotic nodule in the liver, and these are the CTs of the patient with the very big kidneys. Liver transplantation cures the liver condition in these patients, and it holds the possibility of hepatocellular carcinoma. But what about the effect of liver transplantation on the kidney? This is not really known up till now. As succinyl acetone, the offending material in cases of tyrosinemia, is still detectable in the blood and urine after liver transplantation. It is produced from other sites, including the kidney. These patients need long-term monitoring, and we are not sure if we still have to use NTBC in these patients. We have never used it in our patients yet, post-transplant, I mean. You can see here, these are the first three patients who were transplanted for tyrosinemia. And you can see the succinyl acetone has markedly dropped, but it didn't reach the baseline. Then I'm going to move to another case, another condition, that is homozygous familial hypercholesterolemia, in which the LDL receptor is deficient. And this receptor is mainly expressed in the liver. The result will be a very high LDL cholesterol, very high LDL cholesterol resulting in cardiac affection and cardiac death. When are we supposed to do the transplantation? When the LDL cholesterol does not respond, the level does not respond to medical treatment, which is usually the case in homozygous patients. Timing of transplantation, we have to give the patient the chance of transplantation before major coronary disease affection. Otherwise, we'll need to do cardiac transplantation as well, which is not something available here. The outcome of transplantation, there is rapid reduction of the cholesterol levels, then xanthomas disappear. The LDL cholesterol does not normalize because it is deficient in other sites as well. The receptor is deficient in other sites other than the liver. So the LDL cholesterol does not normalize. The patients are maintained on statins, but low doses, and the levels of the cholesterol are within normal levels if they are given statins. The donor is usually not the parent because this is a co-dominant condition and we can't use parents in this case. In this case, we resort to other parents other than the other relatives, other than the parents. You can see here the 4 of our cases. You can see the cholesterol level before transplantation and the cholesterol level after transplantation. It hasn't reached the baseline, but yet it is controllable by statins. Otherwise, it hasn't been controllable by statins pre-transplant. Then we move to the other type of transplantation, which is transplantation for non-structural metabolically liver-based metabolic diseases, mainly the urea cycle defects and the organic acidemias. In the United Network of Organ Sharing database, 5.4% of all pediatric liver transplants between 2002 and 2012 were for UCDs and organic acidemia. I think Dr. Moeen and Dr. Magda have mentioned the need for liver transplantation for in the case of urea cycle defects. We know that the urea cycle, the site of the urea cycle is mainly the liver, and liver transplantation is indicated because of the hyperammonemia and the progressive liver disease in case of succinyl argininosuccinate lyase deficiency. So in this case, the hyperammonemia, if it is uncontrolled, liver transplantation would be the only option. Transplantation has resulted in high patient and graft survival. It's the same as transplantation for any other liver disease. There were no episodes of hyperammonemia occurred post-transplant, no dietary restrictions, and there was a potential improvement in the neurocognitive function, especially if the patient has been transplanted before the neurocognitive dysfunction has occurred. In a consensus statement, liver transplantation was advocated between ages 3 and 12 months, once the child has weighed more than 5 kilograms, in all types of urea cycle defect, except in NAG deficiency because of the presence of the oral Carbo-Glu, which is through which we could avoid transplantation. Then next is the transplantation for the maple syrup urine disease. The liver expresses 9 to 13% of the total body's PCKDH complex activity, which the activity of this complex when deficient results in MSUD. Muscles express the largest activity, which is 50-66%. And this is important because this is one of the diseases in which we can use domino liver. What do we mean by domino liver? The liver of the MSUD patient is taken out from his body and given to another patient with end-stage liver disease who does not have MSUD. How would he be functioning with a liver which is deficient in MSUD? This is because his muscle will compensate for this deficiency, and he will be able to make use of the MSUD deficient liver, which has been taken out from the from the inborn error of metabolism patient. The first report of liver transplantation for MSUD was in 2006, and this was on 11 patients. The number has now increased, and the last number that I have read is 54 patients. 54 patients have undergone liver transplantation for MSUD. Patient and graft survival is very good, reaching about 100%. There were no attacks of metabolic decompensation occurring while on normal diet. And liver transplantation is thought to arrest the progression of brain damage if it has not occurred. It arrests it, but it does not convert it. Correction of levels of branched-chain amino acids occurred within hours after transplantation. The branched-chain amino acid levels drop immediately after transplantation, within hours. So it's very useful, but it does not treat completely the condition. Liver transplantation for methylmalonic acidemia. Again, it eradicates the episodes of decompensation and results in excellent long-term survival and suggests stabilization of neurocognitive development. Yet there is persistent metabolic abnormalities, meaning that still the methylmalonic acid level in the blood, although it drops markedly, but it's still high. And there is a continuing risk of renal damage after transplant. And that's why combined liver and kidney transplantation may be required in the case of methylmalonic acidemia, especially if the kidney is affected, and even sometimes it's done preemptively. In the case of propionic acidemia, again, liver transplantation reduces but does not eliminate the risk of metabolic decompensation. Transplantation is considered in patients with recurrent episodes of hyperammonemia or acidosis that are not adequately controlled with medical therapy. So we don't go for transplantation for the propionic acidemia patient, except if he is uncontrolled medically. His metabolic crisis is uncontrolled medically, and he gets recurrent attacks. And again, in the case of propionic acidemia, as in other metabolic diseases, we should be very careful pre-transplant in the proper selection of the patient, because if he has propionic acidemia has cardiac effects. And so we have to meticulously examine the heart of the patient, as well as his renal condition. Recipients of living-related donor livers seem to have similar results to OLT recipients, so we can use living-related donors in this case. And thus, in conclusion, liver transplantation is a cure for some inborn errors of metabolism, as hepatorenal tyrosinemia, Wilson's disease, urea cycle defects, but it ameliorates the condition and does not cure it in the MSUD, methylmalonic acidemia, and propionic acidemia. Timing of transplantation is essential. It is very important to choose the proper time and not to postpone transplantation too much, so that extrahepatic organs are not affected to an extent that prevents transplantation. And thank you very much.
Thank you, Dr. Tawhida. I have one question from Nada. How can we get a donor if we can't take from parents they are co-dominant in homozygous hypercholesterolemia? Can we take donors from outside the family?
In our patients, we used sometimes the uncle or the aunt, pre-transplant, we have to measure their cholesterol level, their LDL level, and so on, and to make sure that they do not carry the disease. And then if we do not find a proper donor from the family, we have the legal chance to get a donor from outside the family. We can, through writing a report of the patient, we can get يعني موافقة بgetting a non-related donor if we have our good reasons. And we have
another
non-related donors in these in one or two of these patients. No, I see the question. Is a carrier state contraindication? No, it is not contraindicated in certain conditions, but it is contraindicated in the case of homozygous familial hypercholesterolemia because it's a co-dominant condition. But in other conditions, in tyrosinemia, we use parents who might be carriers, and we're doing well.
Okay. Another question from me. We had several potential MSUD patients that they were willing to do liver transplantation to avoid the decompensation attacks, and then none of them did the liver transplantation. Why do you think Dr. Tawheed did that?
They didn't do it because we didn't do it, or because they didn't want to proceed with the transplantation?
No, they didn't want to proceed with liver transplantation. They prefer to go on diet even if they have several decompensation attacks.
I think they were not given the proper consultation as regards liver transplantation. Because if you tell anyone you're going to have a major operation where you have to keep on drugs after treatment, after operation, and you have to keep doing medical visits, maybe he will not agree to do this. But if you give him the results of the operation, the results of the treatment, and they tell him that the post-treatment medications are all subsidized by the national insurance, he will not pay anything for the post-transplant medications. And part of the money required for the transplantation is as well subsidized by the national insurance, health insurance. So probably they need proper consultation.
Okay. Dr. Mu'in have another question. We have transplanted many patients. No, it is a comment. We have transplanted many patients with propionic and MSUD. Yes.
We haven't transplanted any.
Yeah.
We have no propionic acidemias in our cohort of transplanted patients. We don't have propionic acidemias nor MSUD.
Neither MSUD.
Yes.
Dr. Nada is asking where can we send those MSUD patients in Egypt who need liver transplantations?
To the liver transplantation centers. To the various liver transplantation centers. We are one of them, but there are more than one liver transplantation center in Egypt. Now,
Dr. Muhammad Imam, is there any long-term follow-up for these patients with organic acidemia? Does the operation prevent cognitive impairment?
It holds cognitive, it might hold cognitive impairment, but it does not completely prevent it, because it is said that some of the material produced is produced in the brain, and it causes persistent brain structural brain damage, which is not reverted by transplantation. They have to be managed through a transplant hepatologist plus an inborn error of metabolism specialist, because you have always to measure their metabolites. You have always to give them sometimes low protein diet as well, not to the extent of low protein that is used in the case of if they have not been transplanted. But they have to be managed by both, and they are not cured. They are not cured.
Okay. Dr. Ma'in have another comment that domino transplant is becoming common in our center. We hope to be like you and do the domino transplant.
No, in Egypt we have done 2 domino transplants. Not common because we don't have transplantation for inborn errors of metabolism as a common cause of transplantation. The commonest cause of transplantation in adults has been HCC and HCV, and in children it has been the cholestatic liver diseases. Metabolic liver diseases are not commonly a common cause of or a common indication for transplantation, and domino transplantation is indicated in very specific metabolic inborn errors of metabolism, of which MSUD is an important one.
Thank you, Dr. Tahida. Professor Dr. Aizat Al-Sokki will present the next speaker.
I'd like first to thank all the speakers for the excellent, informative presentations. And it's my pleasure to introduce Professor Ihab Hakim. He is a professor of pediatrics, and he is the head of pediatric nephrology and dialysis unit in Ain Shams Medical School. And he is one of the board members of the Egyptian Society of Pediatric Nephrology and Transplantation. He is going to talk about peritoneal dialysis versus hemofiltration in cases of inborn errors of metabolism. Please, Dr. Ihab Hakim.
Bismillah ar-Rahman ar-Rahim. Thank you, Professor Aizat, for this introduction, and thank you for the organizing committee and the Professor Sulef, Professor Heba, and Professor Ola for inviting me to share in this interesting session. And it's a difficult task to be one of the last presenters, particularly after Professor Tawhida, but it's made somewhat easy because I'm tackling a different problem, which is the dialysis among the cases of inborn errors of metabolism. Is the presentation clear?
Yes, Doctor.
Okay. Okay. Bismillah ar-Rahman ar-Rahim. Today I'll talk about the peritoneal dialysis versus hemodialysis or hemofiltration in inborn errors of metabolism. And the presentation will be divided into three parts. Well, first is dialysis indications in inborn errors of metabolism. Then I show some previous reports on dialysis in inborn errors of metabolism, and finally, what's available now in Ain Shams pediatric dialysis units. What's new we are having now. First, the dialysis indications in inborn errors of metabolism. I've classified into three parts. The first, the inborn errors of metabolism that may complicate with acute kidney injury requiring acute dialysis. Then we have a group of inborn errors of metabolism causing chronic kidney disease and hence requiring chronic dialysis or transplantation even. And then we have a third group with inborn error of metabolism with accumulation of substances in the circulation causing organ intoxication, particularly the brain. In the first category, we have, for example, the carnitine palmitoyl transferase 2 deficiency. In the second category, we have a long list like methylmalonic acidemia, glycogenosis, type 1, adenine phosphoriboside transferase, Fabry's disease, Wolman disease, porphyrias, cystinosis, and hyperoxaluria. And the third one on which we are going to concentrate, which is our subject today, the accumulation of substances in the circulation causing organ intoxication, and these have been presented nicely by previous presenters in this session. In the pediatric dialysis book 2012, there is a nice table showing the indications of dialysis in inborn errors of metabolism, and showing that some of these are not amenable for dialysis, like the fatty acid oxidation. I mean by dialysis the conventional dialysis. Some of them require other forms of dialysis, but the conventional dialysis methods cannot indicate it in these conditions. Other indications have been described by previous presenters. In the Atlas of Inherited Metabolic Diseases of this year, They emphasize that this is the management of hyperammonemia with a known cause, acute hyperammonemia, and the management is dependent on the level of ammonia. If it's less than 100, we start medical treatment, have been mentioned before, and between 100 and 250, there is to inform, the important is to inform the metabolic clinic. 250 to 500, we have to inform the dialysis clinic, because over 500, hemodialysis or other method of dialysis should be started. And concerning the medical management, the important, which have been discussed in details, the medical management, important points is that when we start dialysis, we have to increase the maintenance dose for every medicine we are using in the management of these conditions. Now we come to previous reports on dialysis in inborn errors of metabolism. There is a report in 2001 from the group of Rome, Italy, describing the extracorporeal dialysis in 10 hyperammonemic neonates. 4 were treated by continuous arteriovenous hemodialysis, and 4 with continuous venovenous hemodialysis, and 2 with conventional hemodialysis. The important here is the details of what they did. For the conventional arteriovenous hemodialysis, they used as vascular access 2 femoral catheters, 18 gauge single lumen. And for the venovenous, they used a double lumen, 6.5 French, 7.5 centimeters long. And for the hemodialysis, they had 2 patients. One, they used the double lumen, and for the other, they used single lumen. We can see here the filter surface area, which is very, very tiny filter for the continuous arteriovenous and venovenous. And for the hemodialysis, the usual smallest size is 0.3 at their time. And for the bloodline, which is important also, they use this one by the manufacturer. This is a natal line and this is the pediatric line. And this is reflected on the priming volume. The priming volume means the extracorporeal blood volume we take from the patient. And this should not exceed 10% of the total blood volume, which is 8 to 8.5 milliliter per kilo. In the arteriovenous, they used this priming volume was 15 milliliter. In the venovenous, 38, and in the hemodialysis, it was 110. Of course, to compensate for this high volume, particularly in neonates, we have to do priming with blood. We fill the circuit with blood before starting to connect to the patient. So we take nothing from the patient. This was the circuit they used for the arteriovenous hemofiltration. You see the very tiny filter. And they mentioned the results they got with every type. We can see here the ammonia filtration fraction, which is very low for the arteriovenous, was fair for the venovenous, and was very, very efficient for the hemodialysis because of the high dialysate flow. Okay. And so they concluded that the success of treatment for short and medium term is strongly related to the rapid identification of the patient and to the time taken to refer. And they recommend, if we start dialysis, to be continuous venovenous hemodialysis. In this review in 2019, the author mentioned the current modalities for replacement therapy available at our time. And you can see here that it's difficult to combine an efficiency with tolerance. Usually what is the modality which is very efficient is poorly tolerated by the patient, except for the continuous venovenous hemodiafiltration, which have a high efficiency and a good tolerability. Here, a comparison between the 3 modalities available: the peritoneal dialysis, the intermittent hemodialysis, and the chronic renal, continuous renal replacement therapy, or the venovenous hemofiltration. We can see that the peritoneal dialysis can be started very rapidly. Within few minutes, you can start acute peritoneal dialysis. The rate of ammonia removal is slow, and so it is difficult to balance the rate of formation. There is no hypotension, no rebound, no vascular access. Equipment is readily available, and it can be used in hemodynamic instability. While the intermittent hemodialysis is less rapid to start, it's the most efficient. Hypotension is frequent, rebound is frequent because it's short-term, and the vascular access is required, but it's short-term vascular access required for a few hours. and equipment is less available, and that is it's not possible to do in hemodynamic instability. The CRRT is less rapid to start and less efficient compared to hemodialysis in the rate of ammonia removal. Hypotension is less, rebound is not critical, vascular access is required for longer time, and the equipment is difficult to be available anytime, and the possibility of hemodynamic instability to be used with, yes, it can be used in hemodynamic unstable patients. And they suggested in this review this algorithm of how to deal with hyperammonemia. In suspicious cases, we have to start pharmacologic treatment for 4 hours. This time is very important, 4 hours only. If there is a good response, continue. If there is no response, you see if you have available continuous venovenous hemodialysis or hemofiltration, you can start it. If not, peritoneal dialysis is still an option that can be started. It's life-saving. It's less efficient, but it's life-saving. And this book, Critical Care Pediatric Nephrology 2019, compared the 3 modalities, peritoneal hemodialysis and continuous venovenous hemodialysis or hemofiltration. Concerning the ammonia clearance, we can see that the best is the hemodialysis, followed by continuous venovenous, but the peritoneal dialysis is not that bad. Okay, it's not that bad. It can be still used. This report this year, a retrospective review from the group of Michigan, and they describe here their cohort of 17 patients with 19 treatments over a period of 17 years. The ages ranged between 2 days and 15.6, but the median was 4 days, meaning that most of the patients, most of the treatments were in neonates. The plasma ammonia level, this was their protocol. Plasma ammonia level above 500, they received the hemodialysis session at the start and then continued on CRRT. And if the plasma ammonia was between 200 and 500, they were treated with CRRT without the session of hemodialysis. They also discussed the risks. What are the factors that affect survival? And we can see here that the most important were the peak ammonia level. If the peak ammonia level was above 1,250, there is no survival. With the peak ammonia level between 750 and 1,000, there is one survivor. Okay, this is a very important risk factor. Also, the second risk factor was no change in ammonia from peak to initiation. That means no response to medical treatment. The absence of response to medical treatment carries a very bad survival for those patients. And they compared the different modalities concerning the survival with the best modality with CRRT and then with the hemodialysis followed by CRRT. But I think this result might be attributed to their protocol in which they use this technique CRRT for the lower levels of ammonia. And they mentioned that providing referring hospitals appropriate hyperammonemia management guidelines and decreasing ammonia level prior to initiation of renal replacement therapy is critical for positive outcomes. Back to the pediatric dialysis of 2012, in which they mentioned some protocols, okay, for the management of different, the dialysis management of different inborn errors of metabolism. And in hyperammonemia disorder, they agreed to start when the serum ammonia was above 300 to 500, and the termination when the ammonia level is below 100. And of course, we frequently measure the ammonia to decide when to stop. The organic acidureas, they mentioned that the methylmalonic or propionic dialysis indicated if 2 of these 4 criteria persist for 3 to 4 hours after the initial treatment. These are coma, gastrointestinal intolerance, pH less than 7, persistent high blood ammonia levels after carbamide glutamate treatment. And they mentioned the CRRT or intermittent hemodialysis are preferred. For the maple syrup urine disease, 2 of the 3 criteria for more than 3 to 4 hours are indicated for dialysis: coma, gastrointestinal intolerance, or plasma leucine level above 1,700 micromole per liter. And we terminate when the plasma leucine is below 1,000. Peritoneal dialysis is a method of choice, but also the CRRT is a good choice for this management of these cases. The important difficulty here we face that the levels of plasma leucine level are not easily measured, and the results are not rapidly available like the ammonia, and so we cannot frequently measure and manage accordingly. And so what's now available in Ain Shams pediatric dialysis unit, in our unit, the PD was and still is available, the acute PD, as a method of intervention for the critical cases. And it was the only method we had for several years. Until now, for intermittent hemodialysis, the first problem we had was the vascular access. And now we have double lumen, 7 French, 10 centimeters catheters that can be introduced either by the ICU team or the intervention radiology team, ultrasound guided, and this made possible to perform the dialysis, whether intermittent or CRRT. Also, they use the hemodialysis machines, the conventional hemodialysis machines, and as you see, the hemodialysis machines, the blood line, here it is the adult line, which needs primary volume 160 milliliter. But now we have the pediatric line with a primary volume 117 milliliter, and also under trial, still first manufactured by the company, is the neonatal line with primary volume 56 milliliter, which is now available and under trial in our unit. We have also the very small filter, the PED filter, surface area 0.2 meter square with primary volume 18 milliliter. All this made now available and possible to perform the acute intermittent hemodialysis for inborn error of metabolism in neonates particularly. And also we might need priming with blood in every session, and this is possible to be done. The CRRT machine is available also in our hospital, but in the pediatric ICU unit, and they are trained to use it. This is the available machine now. And also we succeeded to get the pediatric kits, which was not available. The pediatric kits is with a total extracorporeal blood volume of 72, 54 for the line, and 18 for the filter. And this made possible to perform the CRRT, the continuous veno-venous hemofiltration or hemodiafiltration, even in the neonates. But also we might need priming with blood. This is the future. It's not available now, the Carpidium, which is specifically designed for neonates, and you can see the very tiny blood line, and the priming volume here is between 27 and 41 milliliters only, and the surface area of the filter is very, very small. Okay, so it can be used in very tiny, even premature neonates. So this is our hope to be available in the future. It's not yet available in the Egyptian market. So in conclusion, the criteria for dialysis and optimal modality to use are not yet well established for each disease and are currently based on individual institutional experiences. The decision is made, and actually this is what we are doing, with a multidisciplinary approach involving intensivists or neonatologists, specialists in metabolic disease, and nephrologists. Thank you.
Okay, thank you, Dr. Ihab. Because of the time restriction, we have 3 cases from Dr. Nada, Dr. Muhammad, and Dr. Radwa. We'll try, each of you have 8 minutes to present his case. Please.
Thank you.
Please, Dr. Nada. Lecturer in medical genetics. Please, Nada, start. Thank you.
Professor Sulef. Hi, is it clear? My sound is clear?
Yes, your sound is clear, but there is no case
presentation. I think I might need the help of the support team. I sent to them the presentation.
Yes, Dr. Nada, we are ready.
Can you upload it? Yes, thank you. This is a case presentation sharing our experience with a case of urea cycle defect. This case is talking about two siblings that were diagnosed carbamyl phosphate synthetase deficiency type 1. Next, please. Next slide, please. Support team, I need the next slide.
Doctor, I am changing the presentation. I will start from the beginning, okay?
Yes, yes, please. It's a case of two siblings. The first one was a neonate, was delivered through vaginal delivery. He was full term, 39 weeks, and weighed 3,200 grams at birth. His antenatal history was uneventful, but there was positive family history of 2 cases of hyperammonemia on the paternal side. At that time, we advised the family to perform a serum ammonia level as selective screening for any neonate in the family. But for this kid, the parents were non-consanguineous. That's why they thought there won't be a recurrence risk. But unfortunately, there was a recurrence risk, and the mother, although she wasn't a relative to the father, but she was carrier of a mutation on the same gene. This is a pedigree showing the other 2 affected cases on the paternal side. Paternal aunt, she was having 2 kids with hyperammonemia, but without specific diagnosis. They were diagnosed a long time ago, and at that time, molecular study wasn't that available. But they were definitely cases of urea cycle defect. Next slide, please. This case was presented on day 3 of life with lethargy and poor feeding. So serum ammonia level was performed, and it was high, 190 micromole per liter. We performed tandem mass spectrometry and organic acids in urine, and they all show normal results. So we suspected that it could be an X synthetase deficiency or CPS1 deficiency. Yes, please. The patient was put on IV fluids and emergency management, including high caloric intake and protein restriction. He was given sodium benzoate by nasogastric tube. We didn't have to perform dialysis. At that time, he was rapidly controlled. He lived for 2 months on protein restriction, and he was doing well and growing. He was given essential amino acid formulas prescribed along with artificial milk. And of course, Ducal was added at that time to increase the caloric intake. The patient was doing well, as I mentioned, for the 2 months, but unfortunately, at the age of 2 months, the patient experienced an attack of gastroenteritis. He was admitted, and he rapidly deteriorated to sepsis, upon which ammonia level was elevated. But unfortunately, the sepsis was mainly the cause of death. Blood culture showed Klebsiella infection, and the baby died at that time, at this admission. Yes, next, please. We could convince the parents to withdraw a sample, a blood sample, to perform molecular study for this patient, and it was actually withdrawn just before death, pre-mortem. And we sent it for molecular diagnosis after death of the baby, and he was found to have heterozygous variants of CPS1 gene. This slide showing the two variants. We counseled the family at that time that both parents, although they are not consanguineous, but they are carrying a mutation in the same gene, 2 different mutations in the same gene. We offered them to perform a targeted variant analysis for both of them, and hence antenatal diagnosis next pregnancy, or even a prenatal genetic diagnosis. But the patients refused, and they didn't perform even the targeted variant analysis. So 1 year later, a female baby was born to the same family. She was delivered through vaginal delivery. She had uneventful antenatal history, but on day 3 of life, unfortunately, she started to develop persistent crying, refusal of oral intake, and lethargy. So this baby was added to the pedigree. Yes, please, next. Okay. The baby was admitted in the neonatal ICU, but with high ammonia level 400 micromole per liter. We also proceeded to emergency management, protein restriction, sodium benzoate, and arginine, till ammonia was reduced to 80 micromole per liter. She was discharged 1 week later, and she had 7 months of being of fair general condition, growing on protein restriction. Sometimes the parents could provide, or we could provide the special formula, the essential amino acids, but most of the time she was on protein restriction of the natural protein, along with sodium benzoate and arginine on high doses, because the patient frequently had hyperammonemia. Her ammonia level was all the time ranging from 100 to 130 micromole per liter. Targeted mutation was done to this baby based on the molecular study of the previous baby. And we found also the 2 mutations for her SIP. Today, the baby is about 1 year old. She had nice days all over the first 7 months, but unfortunately, starting from 8 months, she had many hospital admissions, nearly 1 admission per month, precipitated by febrile illness and teething, and all the time, even between crises, she was not tolerating more than 0.75 gram per kg per day, which is far beyond the minimal safe protein intake, as Dr. Iman said. But we couldn't increase protein intake, especially that essential amino acids is not available now, and we depend on the natural protein. She's currently on 0.75 gram protein, and she's having maximum doses of sodium benzoate and arginine. And yes, Professor Ma'in, if we move to next slide, we discussed the last slide, I mean. We discussed with the parents the option of liver transplantation, but they are very much afraid of the complications. We left them to be free to decide, but nowadays when the patient is experiencing more serious attacks of acute decompensations, sometimes it's not precipitated by an obvious factor. Sometimes it's just, yes, but we don't have sodium phenylbutyrate, Professor Ma'in, unfortunately. We hope we can get it someday in our institution. But up to now, we're so limited to protein restriction. It's cheap, but maybe it's not available due to its, maybe it's not present in the market, and or it have a problem in the license to be present in the Egyptian market. We can ask the manufacturing institutes. But currently, we're very limited. Even essential amino acids are not available, and we're just limited to natural protein, sodium benzoate, and arginine, with the local GIT antiseptic to help the baby reduce ammonia production from bacteria flora. This is our experience. I'm so happy to share it with you, and thank you for listening.
Thank you, Dr. Nada, for your presentation. Dr. Ola will present the next speaker.
We do have Dr. Radwa. She is MD researcher in medical and clinical genetic specialist. She will introduce another case scenario. Please, Dr. Radwa.
Thank you, Professor.
Please, you do have.
Thank you. Can you hear me?
Yeah, Dr. Adwa, please. You have around 7 minutes, please.
2.5-year-old boy presented at the age of 5 days with poor suckling, disturbed conscious level.
Share the screen, Dr. Radwa, please. Press share screen. We couldn't see your presentation.
Dr. Radwa, you will find the share screen button at the bottom.
Can you see now?
No, not yet.
Can you see now?
Yes, doctor. Continue, please.
2.5-year-old boy presented at the age of 5 days with poor suckling, disturbed conscious level.
Sorry, doctor, but can you make it full screen?
Can you see now?
Yes, thank you.
2.5-year-old boy presented at the age of 5 days with poor suckling, disturbed conscious level. He is 6th order of birth of second cousin consanguineous Egyptian parent. He had 3 sepsis in the neonatal period, presented with poor suckling, convulsions, and coma. He was born full-term cesarean delivery, birth weight 2.5 kilograms. Antenatal history were unremarkable. The patient was normal till age of 4 days, and he developed poor suckling at the age of 5 days and disturbed conscious level. He was admitted to the NICU on the 7th day after birth for 11 days with Glasgow Coma Scale 7 and abnormal pattern of breathing. He was intubated. At this point, inborn error of metabolism was suspected. Further investigation were done. Metabolic screen revealed elevation citrulline level 2,570 micromole per liter. His serum ammonia level was elevated 350 micromole per liter. The diagnosis of citronemia type 1 was suspected based on elevation of citrulline level more than 1,000 micromole per liter and elevation ammonia level. The patient was treated with sodium benzoate 500 mg per kg per day and arginine therapy 500 mg per kg per day, but he was unresponsive clinically and biochemically to the medical treatment. Then urgent peritoneal dialysis was started immediately for 4 days. After stabilizing the patient, he started natural protein 0.25 gram per kg per day with gradual increase. This table showing the ammonia level during NICU admission. Then the patient referred to our genetic clinic for further assessment and follow-up. He was following up every month during the first year and every 4 months during the second year. His ammonia level was within normal range. General and systemic examination were unremarkable. He had mild developmental delay, mainly cognitive. Now the patient on 1.4 gram per kg per day natural protein, sodium benzoate 250 mg per kg per day, arginine 400 mg per kg per day. The patient was maintained on stable metabolic control and he didn't develop any metabolic crisis or hospital admission. Citronemia type 1 is an autosomal recessive disorder present as neonatal acute form and milder late onset form. Main clinical features of citronemia type 1 include poor feeding, vomiting, lethargy, convulsions, and early death may occur if not treated. Citronemia type 1 is diagnosed with elevated plasma ammonia concentration more than 150 micromole per liter and plasma citrulline more than 1,000 micromole per liter. Hallmark of therapy include lab lowering of plasma ammonia concentration and reversal of catabolism. Continuous hemodialysis or peritoneal dialysis should be started urgently in patient unresponsive to dietary and pharmacological treatment and continuing elevation ammonia level above 500 micromole per liter. Peritoneal dialysis was effective in decreasing the ammonia level and improving the patient's general condition. Conclusion, citronemia type 1 can present with hyperammonemic encephalopathy which could be lethal if not treated appropriately. Peritoneal dialysis proved to be an effective therapy of reducing the plasma ammonia rapidly and improving the outcome of the patient. Time of peritoneal dialysis is very important, as two factors determine the prognosis of neurological damage, the duration of hyperammonemic coma and plasma ammonia level. Clinical awareness of the disease and neonatal screening are very important for better outcome of the patient. Thank you.
Thank you.
Thank you, Radwa, for your nice presentation.
Thank you, Dr. Radwa, for presenting. I have to close after 5 minutes. So it will not be possible to present Muhammad case, but we will record it and include it in the presentation in the website. We have to close now. We thank you all speakers and professors who spend their time in sharing their talks and experience. Thank you, Dr. Happerly, for sending your talk. You have only one question since the first lecture. Can you explain more about Region 4 stork screening method, Dr. Happerly?
Can you please repeat the question? I didn't get that, sorry.
It is in the Q&A. It is about the screening method you mentioned in your lecture.
Okay, which question is it?
It is the only question in the Q&A box. Can you explain?
It is in the problem of sensitivity in newborn screening for proximal UCDs.
I see the chat, but I don't see the questions and answer.
In the slide of the heading, the problem of sensitivity in newborn for proximal UCDs, when you spoke about glutamine.
Right.
The bottom, there is a Region 4 STROC project used citrulline, arginine, alanine.
Yes.
There is one question.
What's the question here?
There is one question, they need more explanation.
Okay, I see that. Can you explain more about Region 4 stork screening method? Yes. This is a screening project that basically Piero Rinaldo introduced. He is one of the leading newborn screening experts working in the US at the Mayo Clinic. And they have a large program in which they accumulate data from newborn screening, and they do it very precisely from each and every newborn, and they record the exact time that they collect the blood sample. So they have a vast amount of data from newborns, and that allows them to give reference ranges as percentiles, extremely precise in terms of the timing of the sampling. And by that, they are able to see slight differences of the amino acids. And this is much more precise than if you just collect a sample on day 3 or on day 4. And so by their ratios, they are able to have a more sensitive tool to detect proximal urea cycle defects. Does that explain a little bit better?
I guess it's more than what the question needs.
Okay, thank you.
I think just now we are in the end of our session today, and I'd like to thank all our guest speakers, our national and international speakers, our chairpersons, our colleagues who participate by sharing for our virtual meeting. And actually, I think this is because of the COVID-19 crisis. If we do have time, I think this presentation could be in more than 3 hours. I think it needs 3 days. And hopefully, inshallah, on the coming Congress would have more than this time, and hopefully it will not be virtual. Thank you all. And I would also at the end to thanks Dr. Ashraf and Iris Group for all the perfect presentations and intervention with us. Thank you.
Thank you very much. Has been interesting.
Thank